Recording in progress.
Okay. Shall I start, Nathaniel?
Yes.
Yeah. Okay. Hello, everyone. Welcome to all of you to the second day of the Bloodless Medicine and Surgery Society 10th Annual Scientific Conference that is held today. The first day was held yesterday, and we had three very good speakers. And let me introduce myself. My name is Jamila Sathar, and I'm a consultant hematologist at Ampang Hospital, Malaysia. And my co-moderator is Dr. Louis Su. He's the professor of pediatric hematology and director of pediatric sickle cell program, University of Illinois at Chicago, USA. Dr. Su?
Yes.
Yeah.
Hello. Hello from Chicago, 6 o'clock in the morning here. The conference started yesterday with very interesting talks on the conference theme, Medical Informatics, Advancing Bloodless Medicine. And today we'll have two scientific sessions and an industry session. Before we start, Dr. Jamila will remind us about housekeeping rules.
Jamila, you're muted,
Jamila's
please.
Muted right now.
Okay, sorry about that. Okay, so the housekeeping rules are all questions should be placed in the Q&A section. Minimize chats during the talks so as not to distract other attendees and the speakers. The program is being streamed live on BMSS YouTube channel. In case anyone has difficulty with Zoom, see your YouTube link in the chat or type Bloodless Medicine and Surgery Society in YouTube search. Any other housekeeping rules or information you consider relevant? Over to you, Dr. Su.
Okay, thank you, Dr. Jamila. And the Malaysian Society of Patient Blood Management, MyPBM, is an organizational affiliate of the BMSS. And the first scientific session today is MyPBM session on the pillars of bloodless medicine. The first talk is a keynote address, Raising the Hematocrit Without Blood Transfusion is Evidence-Based, by MyPBM president, Dr. Yi Yap. Let me give a bio for Dr. Yi Yap. Dr. Yi Yap, MD, is clinical hematologist and president of the Malaysia Society of Patient Blood Management at Ampang Hospital, Malaysia. Dr. Yi Yap is a clinical hematologist who is working in Ampang Hospital, Ministry of Health, Malaysia. She did her fellowship at hemostasis and thrombosis in Australia, acquired the FRCP PATH UK in London, UK in 2020. She's also the president of Malaysia Society of Patient Blood Management, has been practicing patient blood management for many years with Dr. Jamila Sathar, who is pioneer of PBM of the country. Dr. Yap.
Well, thank you so much, Professor Su, for the wonderful introductions, as well as Dr. Jamila. I can see the smiley face of my boss over there. So without further ado, I'll just proceed with, I hope you all can hear me well. So are we talking about this raising hematocrit without blood transfusion, yeah? This will be my outline. I will bring you through some of the prevalence, evidence, and ABC of PBM, and followed by case scenarios. So about the prevalence of our anemia globally. This is actually from World Health Organization. So you can see the figure is quite alarming. It's about 2.9 billions over individual with anemia and micronutrient deficiency. You can see it down there with either with following surgical interventions or non-communicable diseases, oncological, hematological malignancy. And out of all this, 600 over million individuals actually with chronic or acute blood loss or any bleeding disorders, either due to GI bleeding, hemoglobinopathy, coagulopathies. And with these statistics, there are 40% of the children are anemic, ranging from 6 months to 5 years old. And for pregnant women, about 37% of them. And for reproductive age women, 15 years old to 49 years old, there's about 30% of them. So it's pretty significant health burden for anemia. Now, this is one of the clinical and economic outcomes of the Western Australia Patient Blood Management Program that was implemented from 2008 to 2014, which was published in World Health Organization as well, how it actually improved patient outcomes. You can see by the mortality, it decreased by 28%, infection 21%, acute myocardial infarction, stroke decreased by 31%, and even length of stay 15%. And even improving the key program indicators. Your preoperative anemia 21 dropped to 14%, pre-transfusion HB 7.9 to 7.3 grams per deciliter, and a single unit of transfusion markedly increased from 33% to 64. And the reductions of units of blood transfused, you can see the highest would be your red blood cells, which is 41%, plasma is 47%, and platelet is 27%. And most importantly is we're looking at cents and dollars with this kind of program that's being implemented. You can see the product cost saving up to $18.5 million. And the activity-based cost savings, $80 million to $100 million. It's really, really significant. Now, this is the 3 pillars of patient blood management. My talk will be focusing on pillar 1, detection and management of anemia and iron deficiency, which involves routine detection, evaluation, and diagnosis, or even to find out the cause and management of anemia of iron deficiency as to clinically appropriate management and treatment. Now, this is ABC of PBM. It was actually coined by Dr. Jamila, anemia, bleeding, and coagulopathy for pillar 1. If you look it through, which I know a lot of you are like Professor Su, I hope you agree with me, whereby we every time see a patient, we have to go through a very thorough clinical history. Yeah. So to identify what is the cause of anemia. And 90% of the time, we will be able to derive the diagnosis. For example, if someone has a dietary deficiency or someone is actually on drugs like antiplatelets or anticoagulant, or whether someone is actually having like acute GI blood loss, for example, like telling you they have any like parectal bleeding or any malignant stools, that will actually trigger whether patient is anemic, or even for women with reproductive age, like with heavy menstrual bleeding, yeah, as well as other constitutional symptoms where people will actually ring an alarm bell, for example, like unexplained fever, unexplained weight loss, unexplained reduced appetite, which will point towards malignancy. That will actually, we do not stop investigating the cause of anemia there, but we shall find out the underlying big C for the patients. And secondly, of course, bleeding. This involves a lot of times, which we are all hematologists dealing with our patients with bleeding disorders. For example, like von Willebrand disease, they always come with heavy menstrual bleeding. A lot of times we just normalize the anemia or normalize the menstrual flow. Or this is actually nothing much. But actually, you come and look into it, a lot of these patients presented with severe iron deficiency and iron deficiency anemia, which was not being emphasized on. And underlying cause as well was not being looked into. Either the doctors are not being educated about, or the patients, most of the time in our culture, they will just keep it to themselves. They don't even come for medical attentions. And the third, of course, is coagulopathy. That will happen with other bleeding disorders as well, like Glanzmann thrombasthenia, even hemophilia, so on and so forth. Now, this is actually a courtesy requested by Dr. Nathaniel. He asked me to tell you all how to calculate iron replacement. So there are two ways of doing it. One is a Ganzoni formula, which you calculate a total iron dose by the body weight times the target HB minus the actual HB times the conversion factor 2.4 plus the iron of the iron stores. For the iron stores, those less than 35 kilos, we use the 50 milligrams times per kilograms to calculate. And for those above 35 kilos, which most of us are, we just use a round figure 500 milligrams as the iron stores. And for the simplified formula, I find this quite useful. You do not need to remember so many numbers, which is just use a target 30 minus the actual HB times 150 plus 500. The difference between these two formula, the simplified formula will actually help you to calculate more total iron dose in comparison to Ganzoni. Now, this is one of the systematic review and meta-analysis to talk about the safety of IV iron preparations. It has around like 103 trials from 1965 to 2013, ranging over 10 over 1,000 patients treated with IV iron. You can see that it has decreased rate of severe adverse events, and the conclusion actually is not associated with any increased risk of severe adverse events or infections. Now, this is another meta-analysis or trial sequential out of 3,000 over patients from 9 randomized control trials for patients with heart failure that treated with IV iron for iron deficiency. You can see the forest plot down there, where those 1,700 over patients treated with IV iron, the cardiovascular death is mainly favor those with IV iron, and the hospitalization and death as well. It's just basically the controls were just being seen as not much of benefits if we just don't use IV iron to treat them. Now, this is another study as well done by Professor Frosler, the anesthetist in Western Australia, where he used an IV iron perioperatively for blood management as a randomized control trial. So this is an elective surgery for the patients of his that he selected like 72 patients with the criteria of ferritin less than 30 nanogram per mils, transferrin saturation on less than 25%, HB less than 12 for female. He was following the WHO, HB less than 13 for male. So the intervention, what he did, he actually gave a dose of ferric carboxy maltose, about 40 of them, over 15 minutes, for ranging from 4 to 21 days before the surgery. And post-operatively, he actually used the HB 0.5 milligram kind of recorded as 1 mil blood loss 2 days after the surgery. And the other group, on the other hand, will be randomized into usual care, either no treatment, continued observation, oral iron, or even allogenic blood transfusion. And he actually evaluated those kind of patients 4 weeks post-surgery with the laboratory and quality of life. Now, this is a type of surgery of all his patients who went through, which is a colorectal surgery. You name it: high anterior resection, low anterior resection, upper GI surgery, gynecological surgery, hysterectomy, laparoscopic assisted as well, compared to the usual care. So it's pretty similar, the both arms of the patient's characteristics. So what he found out that there is 60% of reduction in transfusion rate, whereby the usual care is associated with 31% transfusion rates, whereby the IV iron one is only 12.5. So the impact of treating IV iron alone, just before the major abdominal surgery for those iron deficiency, it decreased the need for blood transfusion 31 to 12%, as you can see. Shorter length of stay, 9.7 to 7 days, and recovery of HB post-discharge, 0.9 to 1.9. Now, this is my case 1. I have a 42-year-old Chinese lady who is a Jehovah's Witness presenter with abdominal pain and dysmenorrhea for 3 months and was investigated for left ovarian cyst in January 2019. She went to the private center and was noted to have left retroperitoneal tumor. It's pretty huge, 6.6, 8.2, and 8.7 centimeters. So the gynecology surgeon actually went in and biopsied the tumor, which the HB showed a smooth muscle tumor, either a leiomyosarcoma or a smooth muscle tumor of uncertain malignant potentials. So what are you going to do? would you just leave the lady behind with the mess? She's having abdominal pain. So a lot of times this Jehovah's Witness in my country, there's a lot of resistance to actually take up this sort of cases because they don't want transfusion. So this gynecology surgeon is the same. So she turned away the patients and the patient come to us. What I did is, of course, I didn't watch and wait. I'd actually do a full blood count on her. And true enough, she has anemia with a HB of 11.3. And her ferritin at that time was actually like barely in teens, like 12 or 13. So what is your next step? Would you actually treat her with IV iron? Of course we would, as a Jehovah's Witness. Secondly, would you actually use erythropoietin stimulating agent? This is quite obvious. It's an absolute iron deficiency. In comparison, like those I was talking to you, those with malignancy or chronic disease, I can tell you that sometimes because of the urgency of the operations, because she has a huge mass that require probably surgical removal. So I actually use erythropoietin stimulating agent in this case to hasten the hemoglobin optimization. Of course, last but not the least, transfusing blood is not an option in her. So she was started with IV Venofer 200 milligram 3 times per week and the EPREX 4,000 IU 2 times per week since 9th of May. And I can tell you that even to convince our general surgeon in my hospital, it was quite a difficulty and challenging because, I went through the multidisciplinary team meeting with them 3 times. So the first time I actually went and talked to her, she actually turned me down and said that patients is a Jehovah's Witness because there's be a lot of bleeding. So she's not going to take up the case. Secondly, I went with the patients as well together to see her. She's still hesitant to take up the case. Finally, the third time, I went with the patients together with the Jehovah's Witness and also the gynecology team this time because it may be the gynecology in origin, the tumors, whereby I promised her to get a cell salvage because she said a lot of blood loss. And then after that, the Jehovah's Witness brothers brought in a form whereby it was written as release of liability, which means if the patient happened to have severe blood loss on table and would not be accepting blood transfusion, it would be the patient's own risk. Then only she decided to take up the case. So I arranged a cell salvage. On 18th of June, her HB improved to 14.8 grams per deciliter. You can see in the span of like 5 weeks. Her platelet is normal, white cell is normal, yeah. So the operation was done where initially the surgeon decided for diagnostic laparoscopy, yeah. Then finally, she saw the mass is too big, then only converted to midline laparotomy and decided to excise the mass. And post-operatively, I can tell you the story whereby initially it's done by the general surgeon. Like Nathaniel was saying yesterday, it was very important to get a very astute, good surgeon, where this particular surgeon initially struggled. I was actually there together with her. So I offer to call in the gynecology surgeon, and thank God he came in and managed to find the retroperitoneal tumors that is possibility from the migratory fibroid. And it was 10 times 8.5. And this is a cell salvage that I got. And this is the surgical field. You can see that time was quite difficult. We're still not able to locate and take out the mass. And finally, when the gynae surgeon came in, he just quite slick and he performed I would say that's really bloodless surgery and removed the fibroid in like probably 15 minutes, I would say. And that is a blood loss from him. It's only barely 200 mils, which in my opinion, I think this cell salvage does not even require in the first place. So this is my case too. The 61-year-old Indian lady who is a Jehovah's Witness again with diabetes and hypertension. She has history of non-ST elevation myocardial infarctions with the stent recently and a history of cervical CA diagnosed 6 years ago at a private hospital with the radiotherapy done 4 cycles, lastly in June this year. She was treated with double antiplatelets, ticagrelor, and also aspirin for the ischemic heart disease because of the stenting. However, because of the double antiplatelet, she was complicated with gross hematuria. And the HB fell to 3 and was intubated on inotropic support in one of the private hospital. So that particular private hospital, I had a word with a cardiologist. So he decided to take my advice and treated her with IV iron and EPREX and get the urologist in, did a bedside cauterization and finally stopped the bleeding. Her HB improved and finally discharged from the ICU and from the private hospital. Unfortunately, because of the stent in the coronary arteries, someone decided to start back the double antiplatelets, which she presented with recurrent gross hematuria again 1 week later to my hospital. And that was a HB initially, which was 8 grams. You can see the HB keep falling throughout the days until 3.8. I tell you what happened. So this particular lady initially landed in my another general surgeon colleagues, where he actually want to manage himself. But unfortunately, the gross hematuria was keep on quite bad, this lady, until the HB dropped to 3.8, where finally the lady has a recurrent non-ST elevation MI again. And this time complicated with acute pulmonary edema, where he finally really talked to me with a TROP T of 1002. This is one of the another iron study markers, which you use to measure the immature reticulocytes, the iron content, the 25 picogram, which is less than 30. And her HB, at the time you can see 3.8 was pretty low. And he has no means to manage anymore because the lady is having ongoing MI with a low HB and would not accept transfusion. Yeah. So what I did, I basically, thanks to Dr. Jamila as well, we went together to see the lady. The lady was basically, we just supportively helped the ladies with the IV iron, monofer that we gave her together with the EPREX, as you can see over here. EPREX, and also we did actually diuretics as well. I didn't give her any anticoagulant as well as dual antiplatelets because the hematuria was so severe. And in the end, because we even get a help from the Jehovah's Witness brother that managed to find this particular intravesical instillin, which is a hyaluronic acid, and we decided to do with the bladder irrigations as well as tranexamic acid. And you can see the amount of IV iron that we bump into her. 5 Cosmofer, 2 Monofer, like Venofer as well. So the moral of the story is actually when there is something bleeding, we just have to stop the bleeding. But because of this lady is a Jehovah's Witness, everybody is so afraid to take her to the theater under the general anesthesia to do the cauterizations, which the private hospital actually did, And I managed to optimize the HB to 6.4 when I used these conservative measures to stop the gross hematuria in this lady. You can see over this picture, initially she presented with this sort of really thick that we just clot up the whole catheter bladder drainage tubes. You can see over the time when we started using all these measures, the urine start to clear up. Unfortunately, because the medical said that we need to give at least a single antiplatelets, which we did. After that, she stopped for like 4 or 5 days, restarted back and aspirin. And then 2 days later, she hematuria again. This time even worse. Because she has a right femoral catheter, she developed a right lower limb DVT, deep vein thrombosis. And you know what? This time I had a multidisciplinary meetings together with the anesthetist, the general surgeon, the urologist. The first time round was not successful because the anesthetist say that it needs to be having a HB of 8 before can put the patient under because patient is a case of non-STEMI. After that, I of course I don't give up. I keep on talking to the urologist, talking to the general surgeon, try to convince them, please take her. I think the urologist in the end kind of like persuaded by me, transfer her to urology ward in another hospital. And we kind of like taking the middle ground. Okay, fine, she cannot be anticoagulated. So we put in an inferior vena cava filter. And I think she was still hesitant to do the cauterization, for her. So what she did, she was just using the conservative method like what I was using until the hematuria stopped again. But of course, the HB is low. Until at one point, she will hold the CBD. I still remember she called me up, the urologist, saying that, hey, maybe I want to send the lady back to Dipawali. However, unfortunately, once she removed the CBD, the lady developed acute urinary intentions. And she has no choice. Take the lady to the theater under GA, did the cystodiatomy, and she noticed such a huge clots blocking the bladder outlet and the telangiectasia all over the bladder mucosa that contributing to the radiation cystitis or what this lady is having. So she removed all the clots by the urologist, and finally she has a clear urine. And thank God, before she went into the surgery, the HB was 6.5, 6.6, optimized by me. And subsequently, I rescued her with Monofur, and now she's extubated and ambulating well with no bleeding. Now, this is my case 3. I have a 47-year-old Malay lady with newly diagnosed Burkitt's lymphoma from ovarian mass with endometrial thickening, in which she presented with abdominal bloatedness and abdominal swelling. This is Dr. Jamila's patient as well. She was initially suspected to have uterine fibroid, then was undergoing laparoscopic removal of the uterine mass. But in the operating theater, noted there was an ovarian mass looked like malignant. So thank God she took it out, and we sent for HPE, and it's a Burkitt's lymphoma, whereby we treated her with 6 cycles of intensive chemotherapy, R block AB, which is basically based on Berlin, Frankfurt, and Munster kind of chemotherapy intensively over the period of 5 months. You can see 6 cycles. So what happened to her is, this is the imaging courtesy from Dr. Jamila. You can see so huge mass over here for the ovarian mass, so to speak. So what we did, I want to illustrate to you basically, even within my own hematology fraternity, I also have difficulty to convince some of my consultants to use IV iron. You can see this lady clearly, that initially she was in the other wards from the 3rd of July until 10th of September, whereby she was being transfused, where the intensive chemotherapy she was undergoing. You can see the HB trend. It was still low, despite the transfusion up to 900 mils. And of course, because of the intensive chemotherapy, she will go into nadir with the leukopenia. You can see the white cell drop to 0.4 and platelet drop to teens as well, which of course, essentially will be supported with transfusion of platelets. So what we decided, she's actually a very educated lady. So we convinced her that probably can manage with IV iron and EPREX. And she actually took in the idea and agreed to transfer to the other wards, which is more pro-PBM. So you can see we are using IV iron and EPREX over the time, where she was still undergoing the intensive chemotherapy 3 weekly, that the 6.2, 6.2, 6.4, 7.4, that she was sustained with the IV Venofert weekly and the EPREX 2 times per week, 4,000 IU. And eventually, when she has completed the chemotherapy, and we managed to optimize the HB up to 12.3. So this is what happened to her. After the chemotherapy, she achieved the complete remissions. And I think I can tell you why some of my hematologists are not very keen to use IV iron and EPREX in patients with malignancy, because there is a belief that IV iron would be toxic to cancer patients, number 1. Number 2, they also believe that the EPREX or EPO receptor may be present on tumors that may promote the tumor growth. But what I can tell you in this particular case, she has done the chemotherapy in 2019, which is 5 years ago. I still saw her in my clinic, and she's still doing very well. Yeah, she's currently holding an important position in one of the government administrative bodies. This is a real case. In conclusion, it is feasible to raise the hematocrit by parenteral iron plus or minus erythropoietin stimulating agent. And of course, identifying the cause of anemia is essential for the appropriate treatment. And last but not the least, empowering the blood health is the way forward. Thank you very much. Oh, Jamila, I think you're muted.
Okay.
Sorry, I'm so sorry. I'm always muted. Okay, I'm up. Can you hear me now? Thank you, Dr. Mandy Yap, for the excellent presentation. Now we will keep all the questions to the end of all the three speakers. And I'd like to introduce the second speaker. Initially he had trouble getting in, I was so worried that he will not make it. Dr. Wan Faisham, was a professor in the Department of Orthopedics at University Science Malaysia. He specializes in musculoskeletal oncology and traumatology and is currently in Prince Court Medical Center, Kuala Lumpur. Dr. Wan Faisham has published over 70 research papers and 3 textbooks and has received several awards for his contributions to musculoskeletal oncology. He will be speaking on minimizing blood loss at surgery to improve oncological and functional outcomes in musculoskeletal tumors. Dr. Wan Faisham. You're muted, Dr. Wan. You're muted, Dr. Wan Faisham. Can you switch on your audio? Dr. Wan Faisham, can you switch on your audio? I think you're muted.
I think his audio is on now.
It's on?
You may need to try speaking.
So, can you hear me, Dr. Wan? Is Wan Faisham? Because we can't hear you.
Oh, you still have problem to share and muted.
Nathaniel, Dr. Wan Faisham is still having problems to share and unmute himself.
Okay, maybe we can go on to Kevin.
He can't unmute himself.
Okay, maybe we can take on Kevin and then later.
Yeah.
Dr.
Okay.
Faisham.
Yeah. Dr. Wan Faisham, we will sort the technical glitch, technical problem here, and we'll introduce the Dr. Kevin Ng, third speaker, who will come on now to give his talk. Yes. Would
So
you like to? Yeah. Okay.
Great. So thank you very much. Sorry for the adjusting the schedule here. So it's my pleasure to introduce Dr. Kevin Ng Wei Shang, who is Senior Medical Lecturer and Consultant Pediatric Anesthesiologist at the University of Malaya. His love affair with anesthesiology began way back in 2008 in Kuching, Sarawak, where he was inspired to join the field after meeting the many wonderful anesthesiologists there who were able to tie the wonders of physiology to clinical practice. He's currently working to inspire a new generation of doctors and anesthesiologists from his university. His interests include enhanced recovery after surgery, ERAS, pediatric anesthesia, and patient blood management. Besides medicine, Dr. Kevin is passionate in enhancing the welfare of healthcare workers and is actively involved in various organizations in Malaysia which champion the cause. His talk today is getting brought up. His talk today is also a keynote address. Whoops, sorry, is not a keynote address, but his talk today is entitled Optimizing Tissue Oxygenation and Supporting Patients' Tolerance of Anemia Perioperatively. Dr. Kevin. And I think you're in need of unmuting also.
Yeah,
Dr.
they muted
Got
me.
it. Got it?
Can you hear me now?
Yes, great.
Right, okay. Thank you, Professor Su, for the very kind words. I am also one of those anesthesiologists that fell into patient blood management because of the influence of Dr. Jamila and bringing me on and getting me involved. Since then, I've become more and more involved with all of this, and well, we are trying to get more and more people keener on patient blood management here in Malaysia. So today I've been tasked with speaking on pillar 3, which is optimizing tissue oxygenation and supporting patients' tolerance of anemia perioperatively. These are my learning objectives. We're going to be talking about recognizing the key components of oxygen delivery, apply the principles of optimization in the management of the perioperative patient, and then we're going to discuss how we're going to formulate care plans to optimize anemia tolerance. So essentially, oxygen delivery, balancing the supply and demand, and then mixing and matching. So this is the key, this would be the key formula that I would look at when I'm going to talk about optimizing oxygen delivery. So this is oxygen flux or the oxygen delivery formula, where delivery equals to the cardiac output times the amount of oxygen carried by hemoglobin added to the amount of oxygen that is dissolved in the blood. And if you look at this formula, it's very clear that the majority of oxygen will be carried by hemoglobin and very little is dissolved in the blood with a factor of only 0.003. The cardiac output plays a very big role in trying to deliver all of this oxygen to the tissues that are crying out for it many a times. So essentially what we have, after all the calculations that I've already input here, oxygen delivery is equivalent to about 11.5 mils per kg per minute. Now, if you look at that, that is actually above what is required by the body. The body at rest usually requires 3.5 to 4 mils per kg per minute. So that shows that actually we have quite a large room for us to play with, and the body is able to compensate to even greater heights if needed. So what can you modify looking at this formula? So we can modify the cardiac output. So we can modify the stroke volume, can modify the heart rate to increase the cardiac output. HB levels, we've heard Dr. Mandy's presentation before this about how we can optimize the hemoglobin levels. We can provide O2's oxygen supplementation, or I will talk a little bit about it, about hyperbaric oxygenation, and we can reduce demands, oxygen demands, which keeping everything calm for the patient. So we all are quite familiar with the definitions of anemia. I'm sure all of us here are familiar with that. As a whole, perioperatively, I support the use of 13 grams and above as normal and less than 13 as anemic for both male and female patients. So what happens in anemia? There are some physiological changes that happen. The body reacts by increasing the cardiac output. It shunts blood to vital organs. In the renal, two things occur. Erythropoiesis is stimulated, and then in acute hemorrhages, the kidneys are stimulated to induce volume retention. So how are we going to optimize the patient's ability to tolerate anemia? So I've decided to divide it into 3, where we optimize the delivery, we provide the breath of life, and then we reduce the demand. And these are the key points that are involved. So we'll go through it one by one. So the first thing that we can optimize is, of course, cardiac output. Now, cardiac output it can be something that we can do acutely, intraoperatively using pharmacological methods, or we could also improve the patient's cardiac output preoperatively by doing a proper assessment and prehabilitation. So like I said, intraoperatively, we're going to be looking at advanced hemodynamic monitoring and targeted titration and followed by post-op. So preoperative assessment, what are we looking for? We're looking at comorbidities, anything that can affect cardiac function, like Dr. Mandy's case about the patient with a recent MI. Definitely the ability to raise the cardiac output will be less. The oxygen demand from the heart will be more. So these are things that need to be taken into account. So how do we correct this? So an early review in medical and anesthesia clinics is what we recommend to our surgeons. For complex cases, we actually tell the surgeons, if possible, to refer it to us before the surgical date is decided so that we could review and optimize before we plan for the surgery. Ideally, it should be 4 to 6 weeks. For less urgent cases, could be longer. For more urgent cases, a minimum of 2 weeks is needed. So we can then assess the cardiovascular function. What can be done in the anesthesia clinic or a simple clinic itself? We can do effort tolerance through a careful history. We can do a simple ECG. We can do a 6-minute walk test, which has been shown to reflect quite closely with the patient's metabolic equivalents or METs. And of course, then we can refer to our friends, the cardiologists, for an echo, a stress test, and cardiopulmonary exercise testing, which is done by sports medicine physicians. We do lung function tests for those that are indicated, and putting all of it together, we then decide what is the best way that we can optimize. So how do we optimize? We do prehabilitation. We speak to either a peri-op physician or the sports medicine specialist for optimization. We refer to physiotherapy if needed as planned by the peri-op or the sports medicine specialist. We do exercise, nutrition optimization, and of course, anemia correction if needed. Now, all of this requires planning and time. So this requires us to actually, like I said, plan ahead for our patients. So why should we do prehabilitation? It does reduce length of stay. There are a lot of studies that show better outcomes, but there are some that are equivocal. So meta-analysis at this moment is not conclusive due to the low level of evidence and heterogeneity. Right, so how do we do it? Like I said, structured exercise regimes. Our sports medicine consultants will then plan an exercise regime involving stretching, involving some light weights, to optimize the patient. We've done it with some success with colorectal patients, especially those with very high frailty scores. And we try to optimize their nutrition to build up their muscle bulk prior to going for surgery. Emotional support is very important. And of course, cessation of smoking and alcohol. So what's the objective of prehabilitation and intraoperative monitoring is to keep all systems running. Now, this is very essential. So how do we do it? So first thing, we do intraoperative targeted titration for fluids and volume. Now, the aim is to keep the patient euvolemic. Both ways have been shown to have bad outcomes. Either you are under volume or you're over volume, meaning that you are liberal or you are restrictive. Both have shown bad outcomes for perioperative patients. So it's very important that we keep the patient as close to euvolemia as possible. Volume replacement for blood loss is important to ensure cardiac output is maintained. We do this by using standard monitoring or advanced hemodynamic monitoring that I will see in the next slide, as well as strict IO assessment. So what is advanced hemodynamic monitoring? So it's the use of cardiac monitoring devices in patients with large fluid shifts. We frequently use the flow track, which requires an arterial line. The Acumen is a new system that is available that shows you more and more information that can be obtained. We do use some esophageal Dopplers, and of course, the gold standard would be the TEE. The gold standard overall, of course, is the PA catheter, but PA catheters have fallen out of favor recently, and we've switched more towards the pulse contour analysis. So what is pulse contour analysis? Is the analysis of the arterial line using that formula that I gave earlier on for the cardiac output. So these are just screen grabs from various things that we have. So the invasive, we have the advanced hemodynamic. This is the flow track. This is the Acumens. Acumens has slightly more information in the sense that it could predict the patient's likelihood of going hypotensive 5 minutes before the actual hypotension occurs. As you can see, we have lots of information. We have the cardiac output, we have the cardiac index, we have the stroke volume variability. We can then adjust. Looking at all this, we are then trained to adjust it for the anesthetist, to adjust it to determine how much fluid the patient requires. Does this patient, like for example, in this case, the SVR, the systemic vascular resistance is very low. It normally should be in the 1008s to 2002s. So we would require a vasopressor instead of pushing more fluids if the blood pressure was low. So these are things that we are looking at all the time. Now, for those that don't require invasive monitoring, we have something called a clear side finger cuff that can give us similar values and similar assessments without the need for an arterial line. You can just do it just with these 2 finger cuffs. We use this quite a bit when we are doing sick, I wouldn't say sick, but sick, not as sick patients that need monitoring, close monitoring without the need for an arterial line. This is from the esophageal Doppler and of course the TEE. Right. So we've covered how are we going to optimize the hemodynamics, the cardiac output. And of course, the next thing that we have to do to optimize is we cannot pull the trigger. Now, transfusion triggers are very important. We need to be able to assess our patients individually, but at the same time have some guidance in which how much hemoglobin should be targeted before you start transfusion. Now, in patients who refuse transfusion totally, then this is separate. But if patients who do allow for transfusion, we have to be careful not to pull the trigger without optimizing hemodynamics first, with fluids, with vasopressors, before we decide to transfuse. Now, these are the various transfusion triggers that's come about. The only thing that I would like to add in traumatic brain injury, there are 2 new trials that have come out in TRAIN and HeMotion that are actually looking for, that's actually saying a liberal transfusion actually shows better outcomes compared to a restrictive, but all other groups actually show restrictive just as good as liberal. And when we say restrictive, essentially is you only transfuse if the hemoglobin is 7 or less. So this is from the consensus statement. So what should we do? We should discuss every transfusion decision. We should check hemoglobins before every transfusion. We should practice restrictive transfusion except in that certain conditions. And consent for OP should include risk of peri-op anemia and risk of transfusion with discussion on steps that has been taken to address all of this. So things like cell saver, things like whether iron therapy is indicated, EPO, all should be discussed even in surgical consents. Now, why do we need our transfusion trigger? Essentially, we are trying to formulate a transfusion plan. So this is the formula to calculate our transfusion plan. For most of my patients, this is what we do. We calculate at what level would we require a transfusion and try as much as we can to avoid it. So a reminder, before every time that we think to pull the trigger, we stop, check, and review, and we only transfuse 1 pint at a time. So this is experimental, but this was mentioned in some of the notes that was given to me by BMSS about oxygen carriers. I have very little experience with this, but this is what I could gather. Hemoglobin-based oxygen carriers are harvested from human bovine hemoglobins. HemoPure has been reported quite a lot in South Africa. South Africa is licensed for human use. In the US, it's still experimental. Perfluorocarbons, according to UpToDate, it's actually quite widely used. 35,000 transfusions supposedly in Russia. So these are quite interesting things, but like I said, very little experience on my part. So post-operatively targeted transfusion. Now, how often do we see this? IV drip 2.5 liters per day, normal saline, alternate D5. Is this required? A lot of times we are diluting our patients or it's insufficient to meet the demands. Drain losses are often overlooked. NG, CBD, drains, all are forgotten about, and the patient always tends to end up hypovolemic. And then if the HB is a little bit low, instead of correcting the volume because of the that has caused the tachycardia, they transfuse blood. So we have to be very, very aware of that. So going on to my next one, breath of life, we're looking at all of this. The most practical point is propping up your patient. As you can see, FRC is our main oxygen supply. This is what we need. If you're propped up or you're sitting, your FRC improves, your oxygenation will improve, oxygen supplementation as required, teach your patients deep breathing exercises prior to surgery. So this is what we do. Post-operatively, oxygen demands can increase. Ventilation is impaired because of atelectasis, pain, or hypothermia. Oxygen supplementation is indicated if we suspect delivery is low. So what we normally would advise for is to, if the patient is a little bit on the anemic, we should always provide oxygen supplementation. So how much oxygen supplementation? We usually give 5 liters per minute via Hudson mask, going up to 40% oxygen if required. Now, if the patient's ventilated, now this is one of the interesting studies that I saw in severe anemia. This is case studies that they've done, hyperbaric oxygenation, oxygen chambers in severely anemic patients. Now, for example, the patient that Dr. Mandy was giving where the HB of 3.8, if we are trying to buy time for us to build up using IV iron, hyperbaric oxygen supplementation could have helped the patient as well. So effectively, remember what I said about the dissolved oxygen? Now, at hyperbaric oxygenation, where we give oxygenations above atmospheric pressures, what we can do is the normal dissolved oxygen is only about 3 mils per kilo. So we can actually bring that up, as you can see, almost 160 times, which is actually sufficient to meet all our oxygen demands if we leave our patients in the hyperbaric chamber for about 1 to 2 hours per day during that period. So this study by Fener et al. Showed that at a HB of 5.6 at 100% oxygen, the heart rate was similar if to patients who were transfused to 8.9 at breathing 21% oxygen. So that really shows a difference that if you can provide higher oxygen supplies, you can actually bring down the heart rates and improve the hemodynamics. So lastly, reducing demand. So what are we going to do? We have to keep our patients comfortable. Now, I'm going to talk about poorly controlled postoperative pain. So what happens? If postoperative pain is poorly controlled, you're going to get a lot of changes in the body. And the most important is the cardiovascular changes, where there's an increased oxygen demands because of the tachycardia, because of discomfort. So what can we do? We manage the pain, provide good analgesia. We make sure that the patient is very comfortable. Regional anesthesias and continuous wound infiltration is very effective, however, still very expensive. In Australia, when I did my subspecialty training, was really good because we could use the continuous wound infiltrations to great effect. But here in Malaysia, again, it's very expensive. Now, these are other things that I like to show. PONV is post-operative nausea and vomiting occurs quite frequently in operative patients. Vomiting, the retching all can cause an increase in oxygen demands. Being cold or being too hot also can increase oxygen demands. And these are things that you can control simply pharmacologically or by warming or cooling the patient. Now I put this picture here because one of my patients, after cardiac surgery, when he woke up, he told me, I felt like I was in bed with snakes because of all the tubes that's around him. And he got very, very anxious and agitated because of it. And these are pediatric patients. So it's really understandable that with all the tubes around and you're not aware, could feel very uncomfortable, and we should take that into account. Now, the environment. A quiet environment as patient awakens is important. Now, if everything is noisy and busy, you have just awakened and you hear all these noises, you suddenly will become anxious and agitated. And this, again, can increase the oxygen demands. A lot of times we try for pediatrics, we bring in the parents to try and calm the patient. So this helps as well. It should not be like the night markets of Malaysia where it's so noisy and everybody's speaking at the top of their voices. So what do we want? Happy patients, waking up pain-free and comfortable. So how do we formulate our plans? So this is what we do in pre-op, intra-op, and post-op. We pick and choose as per our patient. We've got to decide what is best and what is needed for our patients to meet our desired target. Essentially, maintaining the hemodynamics, controlling the pain, keeping the patient comfortable, and euvolemic. So in conclusion, how low can you go? There's no definite answer. Everything needs to be individualized. We need to know our patients, discuss with our patients what are our options. There is no one transfusion trigger. The fitter the patient, the lower you can go. So prehabilitation is important. If you have hemodynamic monitoring, you can go lower and lower because you can optimize the cardiac outputs better. So remember the basics for improving oxygenation, positioning, analgesia, temperature, post-op nausea and vomitings. Comfort is, of course, the key. So this is my conclusion, the same thing that I've been saying again and again. Optimize our cardiac output, provide a transfusion plan, motivate the patient, provide an analgesia plan preoperatively, intra-op, hemodynamic monitorings, maintain euvolemia, stop, check, and review for every time you think of pulling the trigger, maintain euvolemia post-op, prop up the patients, and keep the patient comfortable. So I think that's the end of my talk. Thank you very much for having me, and I hope you've all learned, picked up something from my sharing. Thank you very much. These are all my references, and if there are any questions or you would like to know more, you can always email me at kevin.ng@um.edu.my. Thank you. Dr. Jamila, you're muted again, Dr. Jamila.
Unmute. I'm also sorry. Okay. Thank you, Kevin, for the wonderful and excellent presentation. We'll now move on to Dr. Wan Faisham. Dr. Wan Faisham, are you ready? Have you got? Yeah. Yes. Thank you.
Is my screen is ready, Dr.
Yes.
Jamila?
Yes. Yes, it is.
All right. Okay. First of all, I'm sorry for the glitch. So my talk will be minimizing blood loss at surgery to improve oncological and functional outcome in musculoskeletal tumor. I'm a tumor surgeon, mainly doing sarcoma. My main part of the topic is to minimize blood loss and to prevent transfusion in this major surgery. We are interested that the blood transfusion have generally negative impact on cancer survival. In general, for the cancer survivals that established in the literature, but just to share a few literatures on sarcoma, does this blood transfusion really have a negative impact? And it has shown that in early 90s, there's quite a number of papers in 1980s to 1990s, and as well as a present paper on single center as well as a multiple center study to show that the cancer survivals have negative impact with blood transfusion, especially during surgery or post-operative or while being up the patient for chemotherapy. Why it is important to have bloodless oncology? Bloodless means that the surgery is bloody for me. It is important that we have to minimize bloody surgery and prevent blood transfusion because evaluation intraoperative margins as well as control of contamination is very important to prevent local recurrent that translates survival outcome of patient. So the whole entire topic, I'll talk about soft tissue sarcoma in general, as well as bone sarcoma. And we'll talk about a concept of a wide margin surgery, the compartment resection that generally will minimize the needs of a blood transfusion and avoid marginal, there be a risk of contamination and local recurrence. That also translates bleeding intraoperatively. Of course, it is a multidisciplinary approach with hypotensive anesthesia as well as medications post-operatively, and inputs of oncologists pre-operatively in terms of controlling the growth of the tumor and to prevent the bleeding intraoperatively. Why so important about margin? Margin translate risk of local recurrence. In sarcoma, when we go very near to the margin, which is the intraoperative field will be bloody, there's needs of blood transfusion, there's more risk of local recurrence. So most of the time, we try to get a wide margin surgery with a cuff of a normal tissue to improve a local control, to achieve a wide surgery, and this will prevent local recurrence and translate the survival. Local recurrence usually carry a negative impact on final survival and systemic failure of tumor control, of malignancy control. In soft tissue sarcoma, what surgeon can do as a local measures is to minimize the blood loss. Discussion with anesthetics, intraoperative hypovolume with a MAP of 60, 70s. Generally, we clip all the vessels from main vessel by exploration, as well as clip the main perforator vessels to the tumor, and slow surgery to minimize the blood loss, coagulate everything. And this is a very important. Plan surgery with a good MRI and minimize blood loss absolutely will control the margins of the tumor for us to achieve a wide margin. And it translates the needs of a blood transfusion because everything is well-controlled surgery. Even in a huge tumor, you can see that with a proper clipping of a perforatus vessels to sarcoma, that will minimize the risk of bleeding intraoperatively, and that translate a good oncological margin. Which is compared to last time when we talk about sarcoma surgery, then most of the anesthetic will prepare 5 or 6 pints of blood, but nowadays because of a modern technique of surgery and the need of blood transfusion become less and less, and most of the time we don't need a blood transfusion intraoperatively. This is an example of what we are doing sarcoma surgery. Well planned with MRI, identify the major perforator vessels that we have to ligate to control before we remove the whole entire tumor. That absolutely will minimize the need of bleeding, minimize the needs of blood transfusion. That include good MRI, PET scan, assess the vascularity of the tumor, and this translate to surgery. You see the MRI shows the very aggressive vessels very near to the tumor that can be clipped intraoperatively and prevent a major bleeding and subsequently minimize the blood loss intraoperatively and subsequently minimize the need of a blood transfusion or no blood transfusion. This is very important in terms of oncological clearance, or what we call to achieve a good margin, wide margin surgery to prevent local recurrence of this cancer, which is very important that translate the systemic oncological outcome of a patient. And even in major massive surgery, retroperitoneal surgery like this, with hypotensive anesthesia, clip all the perforators to the main tumor and secure all the bleeding and mobilize the vessels away from the tumor, there's still less risk of bleeding, but the surgery a bit slow. And the most important thing is the oncological outcome. The margins of the tumor is clear, and that translates the local control as well as a final survival outcome of patient. This one, secondarily, lessen the needs of a blood transfusion even in massive and major surgery like retroperitoneal surgery like this. Second topic is bone sarcoma. When we talk about bone sarcoma, it is very vascular tumor, and most of the time the needs of a blood transfusion. But with modern techniques of surgery using tourniquet and control surgery, compartment resection of the tumor, and the need of a blood transfusion is minimal nowadays. Why? Because it follows the same principle. Mobilize the vessels, clip all the perforators vessel to supply the main tumor, and control the bleeding, and that will translate the good surgical field for us to control the margins of the tumor, and this minimize the risk of local recurrence and good outcome of the in terms of local recurrence and systemic control of the disease. How we get this is by a good preoperative chemotherapy that will shrink the tumor, will minimize the risk of vascularity, and of course the most important thing will kill the remaining tumor. And in general, intraoperatively, it is well controlled, less vascular, and the margin can be well controlled to achieve a good oncological margin and minimize local control. And most of the time, the need of a blood transfusion is less. This is part of a resection. One of the things which is important, when we remove the tumor, we have to reconstruct back with prosthesis. And this lead to a significant bleeding. We rest for a while and allow reperfusion to the limbs and put a tourniquet again for us to prepare the bone defect with a prosthesis. And it is important to do this procedure less bloody. Why? Because cementation is very important in a dry environment. Once we cement the whole entire thing and minimize the risk of acute bleeding, and then we can release tourniquet, at the same time achieve a good stabilization of a prosthesis and good dry environment for prosthesis junction. That also will improve the survival of a prosthesis for early loosening. So this is the whole entire idea of why we need to have a clean, bloodless field and very nice, which is very important in terms of local control of the disease, as well as a long-term survival of a prosthesis. And post-operatively, there's still a chance of bleeding. In our practice nowadays, on top of tranexamic acid, especially intraoperatively, post-operatively, we use a tranexamic that significantly reduce post-operative drain, blood loss post-operatively. And of course, it's established in the literature that it reduces the need of a blood transfusion almost half, 40%. And this is, from my practice, is very good to prevent the need of blood loss as well as blood transfusion post-operatively. This is my regime: 1 gram post-op, as well as local injection. Significantly, the needs of a blood transfusion following a drainage is less with tranexamic acid. A bit on, and this is an example of one of my patient. Good chemotherapy, compartment surgery, minimize the risk of bleeding, and of course, no blood transfusion, even in a massive surgery like this. Then of course, with a good chemotherapy, systemic control, then you can achieve a good oncological outcome and systemic control, even in a very aggressive and malignant tumor like this. So a bit advancement. So we use for the past 10 years argon diatomy, especially to do intraoperative and control bleeding in aggressive bone tumor, which particularly we want to salvage the joint in giant cell tumor, but this is a vascular tumor. How we minimize intraoperatively rebleed is to use argon diatomy. This improve in terms of killing remaining disease in the surgical bed, at the same time minimize risk of acute blood loss following acute release of tourniquet while preparations the bed for control of the disease. Another thing that which is very interesting past few years that we are using ultrasonic scalpel to do an osteotomy. It's combination of heat and cutting procedure that significantly really minimize the acute bleeding following bone osteotomy, which is compared to ordinary traditional method of osteotomy, because it combined the cutting together with a heat that generally coagulate the needs of bleeding from the bone. And nowadays, small surgery and planned surgery, especially avoiding a major vessels, major neurovascular structure, can be done with computer guided. This will minimize error for good local control of a tumor resection. At the same time, because of guided surgery, will avoid sudden injury to the vessels as well as a nerve, and significantly reduce the size of the wound, and it translates the need of blood loss, the need of blood transfusion because of blood loss intraoperatively. And absolutely, with a minimal surgery, there'll be a reasonable good outcome. This is an example on how we try avoid a major axillary artery by using navigation that to prevent a risk of perforators to the vessels and minimize the bleeding intraoperatively and the need of blood transfusion. And of course, minimize surgery, and you can have a reasonable functional outcome. All right. Okay. In conclusion, is there any improvement in terms of a sarcoma surgery for the past few years? The need of a blood transfusion even in vascular sarcoma surgery become less or less because of new concept or same concept of a wide margin surgery, compartment resection that significantly translate the bloodless surgical field and bleeding intraoperatively. And absolutely, it avoid a blood transfusion even in a massive surgery like a sarcoma surgery. Thank you very much.
Thank you, Dr. Wan Faisal. That was an excellent presentation. Now we will open for Q&A. Let us begin. Let me see. Perhaps I will go through the questions that have been answered by our speakers. The first question is, to Dr. Mandy. They would like to know if IV venofer and erythropoietin has coagulability effect, meaning that does it cause, a thrombosis? Secondly, with the risk for iron toxicity, is it safe to administer iron infusion on oncology patients? You wanted to answer that, Mandy, live? I know you have answered it in the...
Yes.
Yeah. I know you've answered it, but yeah. I know you have answered it. Yeah.
Okay, right. Just now I said with the MI and the DVT. I think we have been using the EPREX that has no issues with thrombosis. Yeah, Dr. Jamila, you agree with me? I do not think it basically increases the risk of thrombosis in general. Okay, there's only like very little papers that anecdotally that is associated with increased blood clots formations, but actually it's not true after people have started using it in many cases. Yeah. And about the iron toxicity, I think in oncology patients, right? Yeah, Dr. Jamila had the second questions.
Yes, yeah.
Yeah, I think
Okay.
there's emerging a lot more evidence. People are using it for cancer patients, and that doesn't actually cause. Because if you imagine the like venofer, it actually cover up in a carbohydrate shell. It basically you infuse in the patient's body, as long as you don't break the it's actually thank you very much.
Okay, thank you, Mandy. There is a question to Dr. Kevin. He's also answered it. What are the options if you want to use oxygenation strategy but don't have hyperbaric chamber?
Yeah, that's why I answered. So hyperbaric chamber is not available widely. It's again something that whole of Malaysia, I think we have 3 hyperbaric chambers. We have sent patients for burns patient to the one in our army camp. It's usually available at the dive centers, but I do know Australia does have in almost every major city, and it's something that does enhance healing. But if you do not have a hyperbaric chamber, simple things like increasing the oxygenation, like I mentioned during the study that I showed, increasing the FiO2, that means the fraction of inspired oxygen from 21% at room air to 60%, 80% would already improve the hemodynamics of your patient. So something simple like putting on even a high flow mask at that point in time during the anemia phase is good enough. Now, if you have something more advanced that can give you something more accurate, like high flow nasal cannula or non-invasive ventilation, both of these could enhance the oxygen delivery, buying you time to do what Dr. Mandy is suggesting, correct the iron, correct with EPO. So it's all putting it all together. You must remember the key thing is we optimize the cardiac output, we optimize the amount of oxygen that is dissolved in the blood. Anything that we can do to improve it, we try. But the best, of course, the ideal would be hyperbaric if you have it.
Okay, there is also another question actually aimed probably to both of you, Kevin and Dr. Faisham. Can cell saver be used in oncology? Will cancer cells be reinfused?
Dr. Faisham, you wanna take this first? Then I will. You are muted, Dr. Faisham. You are muted.
I already answered the question that I didn't use cell saver in all sarcoma patients. I didn't use because I'm worried that if there is a contamination, there will be a risk of a systemic dissemination. That's my practice. But the whole idea of a minimized blood transfusion is to control bleeding intraoperatively.
From what I see from your surgeries, you don't really need a cell saver then.
Dr. Faisham, your pictures are all dry. My very different from the surgeries that I do.
No, I go very slow. I'm a slow surgeon.
So, but when we talk about cancer and cell saver, now a lot of debate is still on about it. Even in my center, we are having a lot of discussions. One thing that can be done to reduce the tumor load is to use the leukocyte filters. There are quite a few studies that have actually shown that post-leukocyte filters, and they do pathology on it, when you look through the slides, you actually find very little cancer cells. But there is no strong evidence to say that it is safe at this current moment. So the recommendations from the Association of Anesthetists from Great Britain and Ireland is that if you want to use it in a cancer patient, you have to discuss with the patient about the possible risk. You have to use the filter as much as possible. And if there's any worry of the tumor being cut open and spillage, then you should discard. Now, these are it's very sound recommendation, very logical recommendations. But if you think of it, if we're worried about the cancer cells going in and it's just at the margins and all that you're using, not breaching the cancer capsule itself, the blood itself would be carrying, the patient's own blood will be carrying cancer cells as well. It's just that if you rupture the capsule of the tumor and then there is a higher cancer load, then maybe you may want to consider against. So current evidence cannot say you can use it completely, but at the same time, it doesn't say that you cannot. You just have to use it with all these caveats that I just mentioned.
Any great question? I mean, are there any questions from yeah? Okay. Okay.
There's two more questions in the open Q&A about
what is LDF? There's a question saying, what about using LDF?
Okay.
I'm not sure what is LDF.
LDF. Morton Lerner, I mean, I'm not sure whether you can.
Yeah,
you can, ask your question. I'm not sure whether you're allowed to speak.
Oh, leukocyte. Yeah. Exactly what I mentioned. Leukocyte depletion filters for those, especially high risk for cancer patients and all. I think we answered that.
You answered that.
There's one more question there, Dr. Jamila, for Dr. Mandy.
Yes. Dr. Mandy, thank you for your section. Please, to know from your practical work, how long does it take for erythropoietin to take effect in post-operative cases of severe anemia?
I would say that it normally take about a week to start the effect of EPREX, that you will see the improvement of the hemoglobin. Yeah. But anyway, we always try to incorporate together if you want to optimize it in a short period of time. But if you have not like for pre-op kind of hemoglobin optimization, I think you can just give IV iron for absolute iron deficiency. I hope the panelists will agree with me.
Yeah. Even if you do not correct it immediately after the surgery, as long as you have maintained the volume and all, you can allow a slight anemia going home. And then 2 weeks later, you're going to see the patient at 13, 14, and that's what we see a lot of the times. I do anesthesia for a lot of the muscular onco patients in UM, and that's what we do. We optimize, even though I'm going in for the surgery next day or 2 days, I just optimize. And when I see them back 2 weeks later, they will send me the FBC report and it's perfectly fine. It does improve long term. So the aim is not to improve immediately, just preoperatively, but thinking of long term. So if you correct it, you will see the benefits long term. And that's what we have found.
Can I add something?
Yes,
number one, especially in osteosarcoma, because we give 3 cycles of chemotherapy, surgery within 3 weeks. So that's very important to minimize the bleeding, because post-operatively, we have only 2 to 3 weeks for the patient to recover before the 4th chemotherapy. So that's why especially when hemoglobin of 8 or 9, that period we need a blood transfusion. So that is why intraoperatively or post-operatively we try to maintain 10 for the patient to recover again for fourth chemotherapy. So that's most important thing, especially in osteosarcoma. But the rest of the sarcoma, where the need of chemotherapy, it is not that crucial, then it is okay to give IV ion or tablet ion to improve the patient well-being, hemoglobin.
Dr. Faishan, do you give erythropoietin in your practice? Do you use erythropoietin?
No. No.
EPO can only be prescribed by
because
hematologists and nephrologists. I don't have access.
because in general, sarcoma rarely presented with anemia, unless it is disseminated sarcoma. They are reasonably well patient in terms of chronicity of the problem. If it's not well, low hemoglobin is already disseminated disease, then we subject the patient to oncologist for systemic control rather than surgery.
Dr. Lewis, you want to say something just now?
Oh, I think we need to wrap up for time's sake. There's one question in the chat that's very long.
Yeah.
Probably needs to be answered by typing. But I wanted to say I'm truly impressed with how much is going on in Malaysia. And I look forward to someday seeing a presentation similar to that big infographic about the medical benefits, the economic benefits, everything from Malaysian context instead of Australian only.
Yes. Yep.
I know that the health context is different, but thank you so much. That's all I wanted to say.
So, okay, so we will wrap it up. And thank you. I would like to thank, is it time? Yeah, it's already.
Yeah, so we do thank all the speakers, right?
Okay, yes. So I think we've come to the end of the session. I would like to thank all the speakers. Great talk, all of you. Yeah. There are more questions that we want to ask, but anyway, we can ask, we can email to all of you. Yeah, I think perhaps if you can share your email, I think some of you will also like your slide presentation. Perhaps you can share your email in the chat box. Kevin, Mandy, and Dr. Aisha. I think there are some unanswered questions, as well as some of the attendees would like your presentation, if you'd like to share. Okay, thank you all. And we'll be having our third day, which is tomorrow. And we hope to see you all again. Thank you all, and good night. And it is night here, so good night.
We still have one more session, Jamila.
Yeah, one more session tomorrow.
No, today.
Yeah. Oh, no.
Today,
So
yes.
sorry.
Oh, yeah.
We have so sorry.
Yeah, I think we have another session coming right up.
Yes.
Okay, so this is the sponsored one. I'm so sorry. Yeah.
Yes.
Okay.
Okay, Dr. Jamila, thank you very much.
Thank you. Faisham, thank you. Thank you, Kevin.
Thank you all.
We have another. Yeah, so sorry.
No, thank you so much, Dr. Jamila Sather. We just want to move into our next session here real quick. Dr. Majid Rafai and I want to welcome everyone to the second part of today's conference, second day of a three-part conference that we're having. And everybody that's been able to attend our 10th annual conference with BMSS, which Bloodless Medicine Surgery Society. We are introducing the medical informatics, advancing bloodless medicine as our theme. And going into our symposium is bloodless surgery techniques. Excuse me, I kept on wanting to introduce the symposium along with our actual conference title there. So one of the things we want to do is introduce myself. I'm Sandy Mann. I'm a longtime PBM advocate, nurse advocate. Have been 20 plus years as a nurse, and actually 15 years with advocating bloodless medicine, PBM, starting off early with SABM, as many of you know, and moving into BMSS and supporting such great causes and speakers and greats. So also I want to introduce my co-moderator, Dr. Majid Rafai. He is a professor of pathology and laboratory medicine. He's also an associate director, transfusion medicine and blood bank for the University of Rochester Medical Center in Rochester, New York, in the USA. And so he's going to go ahead and introduce our first speaker.
Thank you, Sandy. Thanks everyone for joining. So our first speaker for this session is Dr. Peter Knight, who is a professor of surgery at the University of Rochester School of Medicine in Rochester, New York, USA. Dr. Knight is a board-certified cardiac surgeon. He is also the chief of cardiac surgery at the University of Rochester. Dr. Knight completed his medical degree from New York Medical College and general surgery residency at St. Vincent Hospital and Medical Center. That was followed by a cardiothoracic surgery fellowship at the University of Rochester, where he is right now. Dr. Knight is a member of multiple professional associations, including the International Society of Minimally Invasive Cardiac Surgeons, the American Heart Association, the Society of Thoracic Surgeons, the European Association of Thoracic Surgeons, and the American Board of Thoracic Surgery. As an educator and leader, Dr. Knight has been awarded the Marjorie Morris and endowed professorship in cardiac surgery and is currently serving in the Dr. Jude Sower Family Distinguished Professorship in Cardiac Surgery. Dr. Knight has also been recognized for his clinical excellence, including winning the American Heart Association Mitral Foundation Mitral Valve Repair Reference Center Award. He has published 2 book chapters, more than 50 peer-reviewed journal articles, and an additional 50+ research presentations. Dr. Knight is our keynote speaker for this session. He's gonna share with us his experience and evidence on the bloodless surgery and the improvements of the outcome in cardiac surgery. Dr. Knight, please.
Thank you, Majid. I'll share my screen. Is everyone able to hear me?
Yes.
Yes, yes.
I think I have the wrong setup. Hold on. Display settings. That should work.
Yes.
Okay, very good. Good morning, everybody, and thanks for this wonderful honor. It's a passion of mine for a long period of time. The annual conference for the Society is a wonderful experience for me. The title of the talk is Bloodless Surgery Improves Outcomes in Cardiac Surgery, Experience and Evidence. I'm Peter Knight, as Majid told you. I'm the chief of the Division of Cardiac Surgery here at the University of Rochester, which is in Rochester, New York. So the topics I just want to touch on, first of all, a little bit about Rochester and URMC, why we got started in this endeavor, some of the data on why this is important, the steps to success and failure, the preoperative tools, intraoperative tools, postoperative tools, and a conclusion. So when I tell people that are not from the States that I'm from Rochester, New York, they immediately think I'm from New York City, which is way down here. But it's about a 6-hour drive from that to Rochester, New York, which is on the southern border of Lake Ontario and is right on the border basically with Canada. This is the University of Rochester motto is Meliora, which is ever better. This is the undergraduate campus here in the foreground, Genesee River, the city of Rochester, and then Lake Ontario in the background. The medical center dominates the campus. This is the medical center. And the University of Rochester is now the largest employer in the city of Rochester. So we got started, a couple of things that just came together. First of all, in the United States, cardiac surgery utilizes approximately 10 to 15% of the nation's blood supply. So it's a big consumer of blood, and if blood is a precious commodity, so reducing the amount of use is obviously very important. But somewhere in the 2012 era, we were approached by members of the Jehovah's Witness community as they wanted us to try to build a more robust bloodless surgery program. And of course, cardiac surgery was the biggest user of blood in terms of the surgical program. We have a fairly large Jehovah's Witness community, and they were going into other areas, most notably in New Jersey, for bloodless surgical intervention. So in order to properly care for these patients, we needed to build a system that would provide high quality care and outcomes while respecting their faith. As it happens, one of the requirements of our training program, we have an integrated 6 residency program in cardiac surgery. The residents all need to be involved in a quality improvement project during their 6-year residency, ideally one project that lasts through most of their training. So that was really a perfect match for us. We recruited Dr. Amber Melvin, who was, I think, a 2nd-year resident at the time, to be one of the champions for creating this thing called an anemia clinic to serve the cardiac surgery patient population being evaluated as outpatients. Ultimately, the anemia clinic got rolled out to the entire surgical program, but in its infancy, it was a cardiac surgery plan. So what sets us apart from everybody else? You've seen some presentations of other surgical problems that can be pretty bloody, but the thing that sets us apart is the antiplatelet therapy and the heparin. So a lot of our patients are on dual antiplatelet therapy because they've had stents or other issues. A lot of them are preoperatively on anticoagulants like warfarin or apixaban. But intraoperatively, nobody does what we do, which is completely paralyze the coagulation system, running an INR that is a minimum of 480 seconds. It frequently is over 900 seconds. And coincident with that, we run the blood through plastic tubing, which results in platelet dysfunction as well as some hemolysis, although the hemolysis problem has really been solved in most modern heart-lung machines. So that's a real challenge in cardiac surgery. So the question, this is a real question in my mind, and the discussion for these last couple of days really revolves around this. Obviously, the goal is bloodless, but I think it's actually less blood and bloodless together. The goal is bloodless, but reducing the amount is also very helpful. So to make this work, and other speakers have talked about this in terms of transfusion trigger, but basically the way I look at this is you should transfuse when it is life-sustaining, and the patient agrees to it, obviously. And I tell all my patients that we will only transfuse you when I believe that it is life-sustaining. To maximize our ability to meet the expectations of the Jehovah's patients, we have to treat them the same as everyone else. Of course, there's an exception that we have no backup plan like we have with other people. So if they are anemic and we can't get it solved in the timeline that the patients are looking for, we may have to delay, as there is no backup plan. But I think the important point is that you can't build a program for a subset of the population. You have to build a program that applies to everybody so that it is internalized in every step of the process. So what do we know for sure? Well, we know anemia is bad. We know transfusion is worse. But really, can we be sure of this? And I'm not sure that the answer has been developed yet, because the two overlap. more anemic patients are transfused than non-anemic patients, obviously. And if a non-anemic patient needs a transfusion, at least in our world, it almost always implies an intraoperative event of real significance and consequence. So I'm not sure you can tease the two of them out and decide what's worse. Anemic patients also have higher STS and Euroscore predicted risk of mortality. And so I think it's beholden on us to try to figure this out and decide what subset of the cardiac surgery population is most affected long-term after transfusion, and which population can we have the most impact on, because in the end, we're trying to help people. So this paper, Perioperative Transfusion and Long-Term Mortality After Cardiac Surgery, a meta-analysis, was a meta-analysis of 39 studies over 180,000 patients, with 61% of the patients being coronary bypass surgery patients, 42% received perioperative transfusion. And the early mortality was much higher in the transfused population with an odds ratio of 3.9 with a significant p-value. Interestingly, and this has always been fascinating to me, and it's been repeated in multiple studies, if you look at the survivors of the procedure and look at their long-term survival at 6.4 years, there's still a reduced long-term survival. So not only is transfusion affecting the operative mortality, it's having a long-term impact on survival with an odds ratio of 2 and a significant p-value. This paper entitled "Fewer Transfusions Are Still More: Red Blood Cell Transfusion Affect Long-Term Mortality in Cardiac Surgery." This is a fairly recent paper from the European Journal of Cardiothoracic Surgery in 2023, March of 2023. It was a retrospective study, but based on prospectively collected data. And in Denmark, it's mandatory. It's a mandatory database. So it includes basically everybody getting cardiac surgery in Denmark. 43,000 patients involved in this study, and it was in CABG, AVR, and MVR patients. They excluded the deaths within the first 30 days. So they took out the operative mortalities to look at transfusion impact. And there were 32,000 patients left. You can see how it breaks down. 9,000 resulted in red cell transfusion and 23,000 no transfusions. And then they broke it down into two timeline cohorts: the early cohort, 2000 to 2009, the later cohort, which is 2000 to 2019. And the red cell transfusion rate went from 30, I can't really read it exactly, it looks like 37% down to about 20%, so almost a 50% reduction, which I think many places have seen as we ramp down the quote-unquote trigger for transfusion, which used to be as high as 9 or so, and is now in many places 7.5, or in our center, 7 or a little lower than 7. But in any case, the circle part shows you not just the red cells went down in the two timeline cohorts from 41%, from 37% to 20%, the overall transfusion rate from 40 to 25, but even plasma and platelets went down. And this was despite patients being probably a little sicker, as the use of inotropes and vasoconstrictors went up a little bit during that same timeline. This is a more graphic illustration, and the upper panel shows a very steep decline in transfusions over time of red cells, which is the red line, and the green and orange are the plasma and platelet, but which also went down, but not quite as much because it didn't start out as much. But I draw your attention really to the middle panel, which is what I really want to focus on. So this is year by year, the number of units of blood transfused on average per year. And the red and blue, which account for the overwhelming majority of transfused patients, are 1 and 2 units. And that, in my mind, is where the protocols can impact transfusion. And you look at the green line, which is pretty small, but that's 7 units or more of blood. I mean, it's really hard to have an anemia plan preoperatively that's going to affect a 7-unit transfusion. Most of those patients have catastrophic events intraoperatively or postoperatively that result in this large amount of transfusion. And the colors are in between. But again, the red and the blue, which are the overwhelming majority of people transfused, are only 1 or 2 units of blood. And so techniques to reduce small amounts of blood, but using multiple techniques all combined, have a reasonable expectation of reducing that transfusion rate. Interestingly, and this is from the same paper, despite the marked reduction in the use of blood products, this Kaplan-Meier curves of survival based on transfusion, which is the solid lines in the 2 time periods, versus the dotted lines, which in the 2 time periods are superimposable. So no matter what, less blood, more blood, different time years, the impact is still significant in terms of 10-year survival. And we have to always keep that in mind when we choose a transfusion. So I asked this question earlier in my talk about, who are we talking about? Who's going to get the biggest benefit? And it turns out that the biggest benefit are on the younger, healthier people. So these are in 10-year increments, less than 60, or I'm sorry, 5-year increments, less than 60-year-olds, 65 to 69, 75 to 79, and over 85 years plus. And the survival curves are different are better in the non-transfused people no matter what. However, much more significant in the younger people, no transfusion versus transfusion, whereas in the older people, as you'd expect, the impact of transfusion becomes less at 10-year survival. And similarly, and comorbidities. So the sicker patients are down here, the healthier patients are up here, and in the healthier people, there's a marked difference in survival between transfused in the red and no transfusion in green. So if you're really sick and old, you're not going to get much of a return on investment in terms of 10-year survival. But if you're young and healthy, that's where the biggest bang for the buck comes in. So one of the gold standards in our business, as everybody knows, are randomized controlled studies. And this has never really been feasible in transfusion for obvious reasons. But there have been some randomized controlled studies looking at different transfusion triggers. And I'm sure everybody who's on this Zoom meeting is probably familiar with the TRIX-3 trial, which was supposedly restrictive or liberal red cell transfusion in cardiac surgery. And this was a multi-center, open-label, non-inferiority trial of 5,243 patients, randomized to restrictive less than 7.5 hemoglobin trigger versus liberal at less than 9.5. And I'm not sure in today's world that this would be considered truly restrictive, although it's probably true in some centers. But in our center, of course, it's less than 7. And I'm sure a lot of people are even less than that. And even at 7, we will pick and choose. Somebody who's doing fine, we usually won't transfuse, a 6.8 or 6.6. But in any case, these were the triggers in the operating room in the ICU, which is usually post-op day 1 to 2. And the primary composite outcome was death from any cause, myocardial infarction, CVA, renal failure requiring dialysis. And the endpoint of the study was either discharge or post-op day 28. So this was not an analysis of the long-term consequence of transfusion. And the result was that the restrictive trigger, 7.5 versus 9.5, was non-inferior in terms of the composite outcome. So they went a little further. 6 months later, reanalyzed these patients. This was published in the New England Journal of Medicine in 2018. And the conclusion was in patients undergoing cardiac surgery at moderate to high risk for death, a restrictive strategy for red cell transfusion was non-inferior to liberal strategy with respect to the composite outcome of death, myocardial infarction, stroke, or new onset renal failure requiring dialysis. So this, I just snapped this from one of our electronic record charts in a patient who was preoperatively in our ICU getting worked up for something. I don't even know what it was, but we're part of the problem. And this is a perfect example of the problem. This is 2 days with lab studies basically being done every 8 hours. And there were more labs. I just grabbed this one from the chart to show you. And basically the labs are unchanged over the 2-day period of time, but we're repeating them every 8 hours. And the consequence of this is this. We went from hemoglobin of 8.5 to a hemoglobin of 6.7, and we didn't even do anything yet. And so, despite being pretty obsessive about blood conservation, we're part of the problem as well as part of the solution. And I think we all have to keep this in mind as we order lab work, that bloodletting is not a good idea no matter what. there are practice guidelines in our societies, and this was the original guideline published by the Society of Thoracic Surgeons and the Society of Society of Cardiovascular Anesthesiologists. This started in 2007. It's been updated a few times. But of note, one of the things that they did include in this was the risks of blood transfusion, which I think really wasn't helpful, because as you can see, the risks that our patients think about, which is, infectious risks, transfusion errors, they're not very common. And I think it belies the real challenge of transfusion. So I don't think putting this in the paper was all that helpful. But the 1 in 100 non-hemolytic transfusion reactions is probably something we all see pretty commonly. But I think it's more than this. It's obviously the immunomodulation that occurs with transfusions that results in the long-term survival issue. So that's the problem, and what to do about the problem is the real question. So for us, we divided into preoperative stage, when the key here is identification as early as possible of anemia, and then treatment of that anemia, which is where the anemia clinic comes in. And the anemia clinic is housed in our Center for Perioperative Medicine. And I can't state enough how important it is to have collaboration between hematologists, the anesthesiologists who run the Center for Perioperative Medicine, and surgeons, because everybody has to agree that this is an important issue that they're going to devote their time to and make efforts to solve. In the ideal scenario, the patient is seen in the surgeon's clinic, which would be, for instance, in my clinic. We identify the patient as being anemic by checking hemoglobin and hematocrit. We develop an operative plan. We figure out whether they're on antiplatelet or anticoagulant medications. If they're anemic, further labs are done as well to further stratify the anemia. And then the patient is sent for the preoperative anesthetic evaluation as well as treatment of the anemia. And most of the time, as you know, this is iron deficiency anemia, and we give them IV iron infusion, which we have capacity to do in the anemia clinic. And that's something that developed over time. So our initial anemia clinic had no infusion center, but now we have an infusion center location that will allow us to transfer to give an IV iron at the same time. And then consultation with the surgeon may be needed to consider delay for surgery for hemoglobin optimization. And of course, we also identify pretty uncommon, but not rarely, hematologic disorders that need to be worked up. So it's had a lot of benefits, not just reducing transfusion, but also identifying other disease states that we might not have noted. At the same time, the preoperative anticoagulation and antiplatelet therapy are assessed and then managed in conjunction with the anesthesiologist, the cardiac surgeon, and frequently with a cardiologist to decide what the best timing is. But as you know, and everybody has talked about this, and it will be continued to be talked about, in a surgical scenario, the biggest factor is intraoperative, and I can't overstate the need for hemostasis, as that's the critical factor. And that smaller, preferably non-sternotomy incisions are also very effective, because no matter what you do, when you divide the sternum and then give them a sublethal dose of heparin of 400 per kilo and an ACT of 500 seconds, the sternum will continue to bleed no matter what. And even with bone wax and everything else that we use, there's still continued bleeding during the 3 to 4 hour operation. But there is no bone incision in the thoracotomy, and so you can get that completely hemostatic at the beginning, and it maintains hemostasis throughout the operation. We use retrograde autologous prime. I'll show you how it's done and what that really is, and there's data to suggest that that's effective. We ultrafilter the blood in this heart-lung machine during the case if we have a lot of volume and the hemoglobin starts dropping. Obviously, use of sealants and hemostatic agents where appropriate can be valuable. Heparin and protamine titration for accurate dosing of these two agents. Routine use of antifibrinolytic agents to prevent or minimize fibrinolysis. Treatment of acquired diseases like acquired von Willebrand's that develops with aortic stenosis patients using DDAVP, as well as DDAVP in renal failure patients, because the renal failure patients have some impact on platelet function, and DDAVP probably works in that scenario. And then cell saver. And the cell saver, I just would mention that some of these techniques in the Jehovah's Witness patient require special attention. So in Jehovah's patients, it's not a transfusion thing per se, it's blood being out of the body and out of contact. So if you keep the blood in continuous contact with the patient's blood vessels, then you're allowed, that's acceptable. That's how the heart-lung machine is usable in a Jehovah's patient. And the cell saver has to be continuously hooked up in conjunction with the, in parallel with the patient's blood system in order for it to really be consistent with their faith. So this is a sternotomy. It's a giant incision. It's 18 inches or so, 14 inches. This is what a minimally invasive aortic valve incision looks like. There's no bone involvement at all. So the incision can be completely hemostatic right at the beginning, even with full dose heparin. This is a minimally invasive mitral incision, similar size, a little more lateral. So does it work? And there are tons of papers on minimally invasive cardiac surgery and its impact on blood loss and chest tube output postoperatively. I just picked this one because I brought this up because of Jehovah's Witnesses. This was a retrospective study of 63 Jehovah's Witness patients. 19 had minimally invasive cardiac surgery, 44 had sternotomy. On postoperative day 1, there was lower chest tube drainage, which was statistically significant. The day of surgery, the hemoglobin was higher, 11.7 versus 10.6. And the hemoglobin was higher on post-op day 1, 12.3 versus 11.2. Not a great paper, but it's repeated multiple times. The transfusion requirement is a little bit harder to prove because there's going to be less numbers of patients. And as I pointed out, a lot of patients wind up being transfused because of catastrophic events. And so anemic or not anemic, it's going to be hard to impact that. But hemoglobin is a reasonable surrogate. So retrograde autologous prime, what is it and does it work? This is a meta-analysis of 21 studies, 11 of which were randomized controlled trials. And it shows that the odds ratio of transfusion with retrograde autologous prime was 0.34. So you're 2/3 less likely if you have retrograde autologous prime to require a transfusion. So, but the question for you guys is, since this is what I do for a living and you guys don't, what is it? So this is the heart-lung machine, and there's a ultrafilter to get more fluid off. This is the reservoir for the blood. This is the oxygenator down here. This is all the tubing, which goes back to the patient. The patient's over here. And it's all primed with crystalloid. And there's about 1,500 cc's or so of crystalloid, which is a significant hemodiluter. And, in a large human, it wouldn't be that big a deal, but in a smaller person, especially someone who's starting out borderline anemic, it's going to have a big impact on hemoglobin immediately. And so what we do with retrograde autologous prime, and I'll show you the video, what we do is basically we allow for the sound. Let's stop in a second. We allow the patient's own blood pressure to push back the crystalloid into a bag, and we fill the whole thing with blood. So the heart-lung machine is not started yet. The connections are all made. The arterial cannula is in. You can see the blood's coming back right here through the filter, coming back into the oxygenator, which is down here. It'll fill the oxygenator slowly. And while it's doing that, what's happening is the fluid is being pushed out into this bag right here. So we'll fill the oxygenator, displace all the crystalloid, ultimately displace some of the blood from the reservoir. And then when it starts turning into blood, which is right here, that's when we shut it off. And then we have this big bag of crystalloid.
Finish with wrap.
The other thing we use when we have borderline numbers in the on pump and we have enough volume is this ultrafilter, which is basically like a CRRT filter, and we can get blood back from that. Fluid back from that. So you can see the oxygenators and reservoir are fairly full, and we're using this to get crystalloid out, and that's a bag full of liquid. So we can maintain the hemoglobin even in anemic and pretty small BSA patients. And then with regard to specific disease states, as I said, antifibrinolytic agents in all procedures requiring the heart-lung machine, which is almost everything that we do. We do some off-pump stuff, but most of the stuff requires the heart-lung machine. DDAVP for aortic stenosis has been shown to work. DDAVP for renal failure has been shown to work. This is a paper from the Annals of Thoracic Surgery in 2011 showing 0.3 micrograms per kilogram of DDAVP and a reduction in blood loss of about 180 cc's on average in patients with critical aortic stenosis. And I would emphasize that it's like saving for retirement. You can't save for retirement with one big event. You got to save for it every day. And in the reduction in transfusion business, you don't save a liter. You save 100 cc's here, 200 cc's there, 300 cc's there, and pretty soon you got yourself a liter, and all of a sudden you haven't had to transfuse somebody. But these are all relatively small numbers, but added up, if you just have a focus on it, added up, it will work. So back to my agenda, you now know where Rochester, New York is. It's not New York City. We're way away from that on the Canadian border. Why we got started was a push by the Jehovah's Witness community, but now it's been translated in institution-wide to all surgical patients. Some data on why this is important, some steps to success, and one of the ways that we fail, which is bloodletting in the hospital admission, preoperative, intraoperative, and postoperative tools, and then the conclusion. So by employing a multidisciplinary approach with standard protocols, anemia can be identified preoperatively and treated. Tailoring the operative plan to specific patient characteristics is helpful. Minimizing blood draws, both the number and the volume, is critical. I can't say enough about the teamwork. Keep the transfusion trigger low or even lower. Bloodless surgery is the goal, but if you can't do that, less blood will do when transfusion is life-sustaining. And Nellie Ora, ever better. Thank you.
Thank you very much, Dr. Knight. It's a great experience and great sharing with us this information. Now our next speaker, Sandy, are you there?
I'm here. Thank you. And thank you, Majid. Thank you, Dr. Knight. That was excellent. We appreciated that you actually showed us where Rochester is. We got over the mystery on that, and as well as that you and your hospital system is delivering exceptional care, not just to the few, but to everyone. So that really was appreciated. We do want at this time go right into introducing our next speaker, who is Dr. Saidu Yakubu. He is an associate professor and then a consultant anesthesiologist. He works for some of he has helped and worked with some of the teaching hospitals in Zaria, Nigeria. In fact, he is working with Ahmadu Bello University Teaching Hospital. He's got a lot of accomplishments under his name. He's some of the things that really stood out to me is how many boards he sits on. He has been he's Assistant General Secretary for Intensive and Critical Care Society of Nigeria. He's also part of SABM. He's a member of the International Association for the Study of Pain. Very many different accomplishments as well. Some of the achievements that stood out to me was he was awarded the Book of Blood Works during the SABM 2024 annual meeting in Phoenix, Arizona, for being #1 on the WAHOVA leaderboard. That must have been exciting.
Thank
also,
you.
Yes, and also awarded International Multidisciplinary Perioperative Pain Prevention and Management Education, which was a grant by the IASP, which is the study of pain, for educating students and staff and continuing research for the year 2020. So we can see you've been very busy, Dr. Yakubu.
Thank you.
I want to move forward and just welcome you, introduce your part, which is perioperative techniques in bloodless surgery, a refresher and update. And so we will not use any more of your time up, and go ahead and please let us all.
Thank you. Okay, is it possible to share my slide?
Nathaniel, do you have them?
Oh, okay. I can see that it's possible for me to share. Oh, okay, please, can you see my slide?
Yes, yes, we can see them.
Okay, it's okay?
Yes.
Good. Thank you very much. Good morning, good afternoon, good evening. I'm Dr. Saidi Yakubu. I'm an anesthesiologist based at the Ahmadu Bello University, Zaria. I'm very pleased to talk about perioperative techniques in bloodless surgery, a refresher and update. The learning objectives are: 1, identify the risks associated with allogenic blood transfusion, and for the patients to be able to list the pillars of bloodless surgery and patient blood management. And number 3, for the patient to be able to describe the perioperative blood conservation techniques. The outline of the presentation, I will introduce the topic, brief history of blood transfusion, blood conservation, patient blood management, blood conservation techniques, and then I will conclude. As a way of introduction, anemia is a common finding in trauma, surgical, critically ill, and pregnant patients. Most patients with anemia receive blood transfusion for correction. However, as we all know, perioperative blood transfusion is associated with adverse events and complications. Again, the supply of blood is decreasing, coupled with increasing costs. Various blood conservation techniques can help reduce allogenic blood transfusion, and it also helps reduce risks and conserve blood supply, and also decreases the length of hospital stay and cost of hospitalization. Bloodless surgery is a comprehensive perioperative approach that improves patients' outcome through the avoidance of allogenic blood transfusion. This is an image showing us the various risks associated with blood transfusion, the risks of transmission of infections such as the HIV/AIDS, hepatitis C, hepatitis B, cytomegalovirus, bacterial infection, parasitic infection, and other risks that are non-infectious, such as acute hemolytic transfusion reaction, febrile reactions, allergic reactions, and transfusion-related acute lung injury. Transfusion reactions could be allergic, febrile, or hemolytic. The allergic ones could be mild or severe. In the mild one, there could just be facial flushing or rash in the body, while severe ones will lead to anxiety or dyspnea, fall in blood pressure. And then the febrile ones are associated with fever, headache, tachycardia. And then the hemolytic one are associated with chest pain, apprehension, body pains, and hemoglobinuria. History of blood transfusion. This was during the ancient time. The use of blood for medical treatment dates back to the 17th century. William Harvey discovered the circulation of the blood in the year 1628. James Blundell successfully transfused human blood to treat postpartum hemorrhage in the year 1818. Blood typing and cross-matching between donors and patients was introduced to improve the safety of transfusion in the year 1907. The blood group O was identified as a universal donor in 1907, and the first blood bank was established at Leningrad Hospital in the year 1932. Blood bank moved towards an all-volunteer donor base in the year 1970, and the first HIV blood screening test was licensed and introduced by the blood banks in 1985. Blood conservation techniques. Blood conservation is a combination of strategies to avoid the transfusion of allogenic blood and to improve its oxygen carrying capacity. It is a team effort involving the surgeons, anesthetists, hematologists, intensivists, pharmacists, operating room nurses, ward nurses, and other physicians. There are pharmacologic and non-pharmacologic strategies. This is an image showing the pillars of bloodless surgery. There are 4 of them. One is to optimize the hematocrit. Second, to minimize blood loss. Third, to optimize tissue oxygenation. And the fourth one is to support physiologic tolerance of anemia. We'll look at each of them. Optimizing the hematocrit. There should be prompt and complete diagnosis of anemia. And then where possible, oral iron can be given to treat. Otherwise, parenteral iron can be administered. There should also be nutritional support. And erythropoiesis-stimulating agents such as erythropoietin can be administered where available. Minimizing blood loss. There is need to take a good history and perform physical examination, such that there should be prompt diagnosis and appropriate treatment of any coagulation disorder. And then there should be restriction of phlebotomies, and there is need to perform non-invasive monitoring instead of taking blood all the time. And then where there is active hemorrhage, pressures will be applied to stop them or elevate the arms or the legs, and the use of hemostats. And then drugs such as tranexamic acid can also be used to stop bleeding. Intraoperatively, there should be normothymia. And then, of course, acute normovolemic hemodilution can be performed. The anesthetist can perform a regional anesthesia where possible. And then, of course, appropriate positioning to improve blood loss. And then meticulous hemostasis and the application of tourniquet where possible, and then cell salvage and reinfusion of the blood collected. And then, of course, where possible, laparoscopic surgery can be performed. Optimizing tissue oxygenation. There should be appropriate oxygen therapy and ventilation. And then where the patient has lost blood, fluid can be administered, crystalloid if the blood loss is less than 25%, and colloids if the blood loss is greater than 25%. And then, of course, appropriate resuscitation. There should be efforts to minimize oxygen consumption. Where the patient is shivering, they should be treated so that they will not consume oxygen. If there is pain, they should be treated for pain. And then if there is infection and sepsis, they should be treated with appropriate antibiotics. And then where possible, inotropic or vasoactive agents can be administered to help raise the blood pressure. And then, of course, modified hemoglobin solutions can be used. And then supporting physiologic tolerance of anemia. This involves a prompt institution of measures to ensure hemodynamic stability, supportive oxygen, and then accelerate hematopoiesis. Limits patient activity in moderate to severe anemia so that they will not have issues. And then there should be point of care testing so that minimal blood will be lost. Normal readings of hemoglobin actually helps to reassure the team that is managing the patient, and then it is important to promptly detect derangements so that the appropriate intervention can be given. It is important to know that with adequate support, patients survive extreme anemia better than receiving blood transfusion, which is associated with a lot of morbidity and mortality. Patient blood management. This is a clinical concept to prevent unnecessary transfusions for improved patient safety and outcomes. It is a multimodal, multidisciplinary approach that requires the anesthetist, medical team, the hematologic team, and the surgical team. When they all collaborate, it helps to give a good patient outcome. It involves early detection and treatment of preoperative anemia and reduction of perioperative blood loss. It also aims to improve tolerance to anemia in the postoperative setting. Patient blood management has been developed as an evolving evidence-based approach with several key goals. One, to identify, evaluate, and manage anemia, as I mentioned earlier, to reduce iatrogenic blood loss, and to optimize hemostasis, and to establish decision thresholds for transfusion. This is a photo showing the pillars of patient blood management. One, to optimize the hematocrit. Two, minimize blood loss. Three, optimize tissue oxygenation. And four, lowering the transfusion trigger. Patient blood management shifts the focus from the product to the patient. Instead of thinking of the blood, we are now thinking of the patient. How can we make sure that the patient receives the best? It views the patient blood as a resource that should be conserved and managed appropriately in order to obtain appropriate patient care. The aim is to optimize the patient red cell mass, reduce blood loss and bleeding, and to improve tolerance to anemia. There are various areas in which blood management should be put into use: preoperatively, intraoperatively, and postoperatively. So preoperatively, the management of anemia using iron, whether oral iron or intravenous iron, the administration of erythropoietin, and autologous blood donation. There should be meticulous hemostasis, short operative time, hypotensive anesthetic techniques intraoperatively, and hemodilation. And then, of course, blood salvage and the use of pharmacologic agents such as tranexamic acid intraoperatively. Postoperative measures include meticulous postoperative monitoring of the patient, early detection of blood loss, and reduction of the collection of blood for tests, and then normalization of cardiopulmonary function and minimization of oxygen consumption. So this is a table showing the various pillars and then the various times. Preoperatively, we aim for assessment of anemia 4 to 6 weeks before the surgery, so that if there is anemia, it can be treated. And then pillar 2, identify and manage bleeding risks intraoperatively, and then minimize iatrogenic blood loss. And then post-operatively, pillar 3, compare estimated blood loss with patient-specific tolerable blood loss. And then intraoperatively, schedule surgery with optimization of red cell mass, meticulous hemostasis, and surgical techniques. If possible, in a surgery where there is anticipation of high blood loss, a surgeon that is highly competent should perform the surgery, a surgeon that is very fast, and then post-operatively stimulate erythropoiesis. And then pillar 3, maximize oxygen delivery. Jehovah's Witness, blood conservation and patient blood management is clinically relevant in surgical procedures involving the Jehovah's Witness. Jehovah's Witnesses refuse the transfusion of 4 main components of blood: the red cells, white blood cells, plasma, and platelets. They also refuse the autologous blood that has been removed from the body. The World Health Organization defines anemia as a condition with decreased number of red blood cells and their oxygen carrying capacity. It is associated with inability to meet the body's physiologic needs. It is quantified by a hemoglobin concentration of less than 13 grams per deciliter for men and less than 12 grams per deciliter for non-pregnant women. Prevalence of anemia before operation has been found to be as high as 60%. Preoperative strategies. As I mentioned earlier, pre-op assessment history, physical examination, review of investigation results, and then history of inherited or acquired bleeding disorder should be documented. Patients should be asked if they are taking non-steroidal anti-inflammatory drugs or other anticoagulants. And then the type of surgery should be considered as it relates to the risks of bleeding. Major, huge tumors associated with huge blood loss. Physical examination must look out for anemia and bleeding tendencies. Severe hypertension may cause severe bleeding. Therefore, all patients that are hypertensive, they need to be controlled. Fluid blood count should be performed 4 to 6 weeks before surgery, and anemic patients should receive preoperative hematinics. Intraoperatively, there should be appropriate management of blood loss, and this could be influenced by the surgical technique, anesthetic blood loss reduction strategies such as regional anesthesia instead of general anesthesia where possible, and then pharmacological management. Laparoscopic surgeries are associated with a reduction in blood loss compared to open surgeries and laparotomies. There should be meticulous hemostasis to prevent perioperative bleeding. Regional anesthesia is an anesthetic blood sparing technique. There should be maintenance of balanced physiology such that hypothermia should be avoided, and then, of course, acidosis aids coagulation. Hypotensive anesthesia reduces blood loss, and appropriate patient positioning assists in reducing blood loss by improving venous drainage. Intraoperative cell salvage. If blood loss greater than 500 ml is anticipated, the use of intraoperative cell salvage is encouraged. This is performed with the use of a double lumen suction device to collect blood. Blood is stored within a reservoir with added anticoagulants. Once blood is collected, the red blood cells are washed, filtered, suspended in saline, and returned to the patient. So this is a diagram showing surgery going on. The patient blood is collected through the cell salver. The blood is washed, filtered, and then retransfused to the patient. Intraoperative cell salvage in obstetrics should be considered in patients at high risk of hemorrhage, and it helps to avoid allogenic blood transfusion. Modern cell savers, they remove most particulate contaminants, and liquid reduction filtering of the salvaged blood before transfusion add further safety to this particular technique. Antifibrinolytics, example, tranexamic acid and epsilon aminocaproic acid. They inhibit fibrinolysis by their action at the active site on plasminogen. They prevent the conversion of plasminogen to fibrin. Tranexamic acid should be used prophylactically in major surgery, such as orthopedic surgery, and then major cancer surgery, where perioperative blood loss is predicted to be high. Tranexamic acid has been shown to significantly reduce perioperative blood loss. This is a diagram showing plasminogen. The way tranexamic acid works, it prevents the conversion of plasminogen to plasmid. That way, fibrin cannot be broken down to fibrin degradation products. Tranexamic acid is recommended as soon as after onset of postpartum hemorrhage and within 3 hours of birth for all causes of postpartum hemorrhage. It should be administered within the first hour after injury too. Again, 1 gram in 10 minutes, that's 100 milligram per minute over 10 minutes should be administered. And second dose if bleeding is ongoing at 30 minutes. Postoperative strategy. The frequency of blood collection for investigation should be reduced. Reduce the use of postoperative drain, and cell salvage can be used to retransfuse blood collected from drains. In conclusion, blood conservation strategies and patient blood management improve perioperative patient safety and outcomes. Though blood transfusion is life-saving, its administration to patient increases morbidity and mortality. All perioperative health professionals should collaborate among themselves to practice blood conservation strategies for the well-being of the patient. Thank you very much. These are my references, comments, and questions. Thank you. Hello.
Hi, thank you so much.
I hope you heard me. Thank you. Yeah.
Very good job, Dr. Yakubu.
Thank you.
Dr. Rafai, did you want to?
Hello? Yep, we're ready for the third
Oh, okay.
presenter for today. Yep. Thank you very much, Dr. Hood.
Okay, so I should stop sharing.
Yes, please. Thank you. And
Thank
just wait until these after the third speaker, then we'll go for the discussion and question and answers.
Thank you very much.
Thank you. Okay, so our next speaker, we are running a little bit late on time, but we will do good. So our next speaker is a keynote address, Dr. Robert Selby. Dr. Robert Selby is a professor of surgery at the Keck Medical Center of U.S. California School of Medicine in Los Angeles, California. Dr. Selby is the director of the liver transplantation program and chief of the division of hepatobiliary and pancreas surgery. Dr. Selby graduated from the University of Missouri School of Medicine at Columbia, Missouri. Before joining USC, Dr. Selby served as a faculty at the University of Pittsburgh, where he trained in multiple organ transplantation and hepatobiliary pancreatic surgery. He remained at the University of Pittsburgh, where he was also director of the Multi-Organ Transplantation Fellowship. Dr. Selby has trained more than 45 transplant surgeons who currently participate in transplant programs throughout the world. Dr. Selby is a board certified in general surgery and general surgical critical care. His research interests include transfusion-free surgery, surgery for neuroendocrine tumors, primary and metastatic liver tumors, periambulary cancers, pancreatic cancers, bile duct injuries, and cholangiocarcinoma. He has scores of publications in his areas of research interest. So Dr. Selby today is going to address the oncology and transplantation surgery without blood transfusion. And he's going to tell us why and how this can be done. Dr. Selby is all yours.
Thank you. You can hear me okay?
Yes.
Give a nod if you can hear. Okay.
Yes.
I'm going to try and share my screen here. And it should be right there. Tell me if you all are seeing it.
Yes, right now.
Okay. So, well, this is sort of an acquired interest of mine, and it grew up kind of accidentally. When I was at the University of Pittsburgh, we did lots of transplants back in the late 80s, and we had transplanted 4 adults that were obligatory transfusion-free patients. And I think 3 of them went well. We wrote up the experience, but it was kind of based on a catch as catch can. It wasn't organized into a program or a broad strategy. And I think probably the hardest part about transfusion-free surgery and patient blood management is building a coalition of interested people and kind of driving it through. And I've seen over the years, a lot of people that are sort of laissez-faire about patient blood management, and very few what I would call true believers. And I think, in some ways it's kind of the ideal platform for somebody who really has an investigative scientific inquiry kind of nature. If there was ever a better control arm than the Jehovah's Witnesses, I don't know what it is, because being obligatory transfusion free, you don't have to persuade them, you don't have to convince them, and for the most part they're not going to cross the line. So they're an ideal background context for patients who are transfusion eligible. So, we at USC, we started our program, and I'm going to show you some slides of what our timeline was. Our program, the ultimate goal was really to develop the strategies and refine them in the Jehovah's Witness population, and then be able to practice them universally broadly for all patients, which has happened pretty much for our service being the hepatobiliary and transplant, but abdominal transplant surgery service. We have a dedicated team. We have dedicated anesthesiologists. They all understand it. They all like the witness patients, and it's a challenge for them, and it's one that they've met successfully. But even in our own institution, I wouldn't say that there's a broad interest or agreement in how to go forward with the Jehovah's Witness patients, and that trickles down to patients who are there and they say they want patient blood management. So there's really not any strategy for them. So let's see.
It's not advancing, Dr. Selby?
I'm just trying to figure out how to advance my slides here. Okay, I guess I figured it out. Okay, I don't have any disclosures. So I was fortunate enough to work with Dom Starzo for about 10 years, and he's he was a very iconic and iconoclastic figure. He developed liver transplantation, and some of the things that we were allowed to do back then, or maybe not allowed but not prohibited from doing, were bizarre, and at the same time they were sort of creating new ground for development. So we, multi-organ transplantation, cluster organ transplants, transplants for malignancy of every variety, all those were done back at the University of Pittsburgh in over a 10-year period, and became kind of a flag in the ground for what is possible surgically. And then the question is it feasible medically, and is it sensible? And one of them, I think, was this transfusion-free transplantation for Jehovah's Witnesses. So the way that we get to a smart patient blood management practice is to use what we've learned in the witnesses, hone it, refine it, and then apply it. It doesn't have to be obligatory in the non-witness patients, but it does allow us to offset, even if it's not complete, to offset the losses that we have in the operating room and have less transfusion requirement, which is even beneficial both from a cost standpoint as well as from an outcome standpoint when it comes to morbidities. So this is our program, and I like most programs, especially our hospital was rather infantile at University of Southern California. It was kind of an infantile hospital. So, it wasn't built from the bottom up. It was kind of cobbled together. And so we started doing witness patients as not big liver transplants and kidney transplants, but we started doing witness cases. And this was back in 1996. And the whole point of this is to kind of show an outline of how we developed a transfusion-free and then subsequently a patient blood management program. So we had a few cases that we did early on, and then we got a liaison to the Jehovah's Witness community. Many of you probably know Randy Henderson. He's been my friend and colleague for 30 years. And that was quite helpful because it really gave reality testing to the witness population that came in and allowed us to present sort of a unified and persuasive front. For some reason, and I'll tell you what the reason was. Back in those days, we were just starting our liver transplant program, and we didn't have any traction because UCLA was across town and they were doing the most. So we decided we were going to do Jehovah's Witnesses, which I wouldn't recommend as an initial step in developing a program. I think it's much smarter to start with the easy things first, practice the utility of acute normovolemic hemodilution and augmentation, see if you can get that to work, and then gradually build your processes within the system and then do the hard cases. But that's not what we did. So in the early beginnings, after we said, well, we're going to have a general witness program, we started with the development of the processes. That means, like, how do you identify a patient? How do you notify the blood bank and administration that this is a witness patient? How do you notify the phlebotomy people not to draw bloods? And how do you get the acceptances and refusals from the patient? And that's gone on. It's been refined some over the years, but that still is in existence for us. And those are basically our critical pathways. And then, so now we're up to 1998. And probably the smartest, arguably the smartest thing that we did was get anesthesiologists involved in the practice, because, in my view, over all these years, that's still the biggest blockade. And if you think about it, the reason is because, anesthesiologists are working on a short-term goal. Their goal is to get the patient out of the operating room safely. So if they're asked to take risks on behalf of the patient, then they're taking risks on behalf of themselves. For the surgeon, you want them out of the operating room, but you don't want them to get a post-op infection. And for the oncologist, you want them out of the operating room. You don't want them to get a post-op infection, and you don't want to get a delayed recurrence of tumor. So, but the first key to developing a blood management practice or a transfusion-free practice is to get the anesthesiologist on board. And then, one of the ways to sort of build a culture of patient blood management is to start tracking your data and then start publishing or presenting at national meetings. And I think probably that's, after getting the anesthesiologist on board, then you've got sort of a partner in the process, and then you start spreading around the presentations and publications, and now you've got something that's got wheels and is starting to have some movement to it. Data tracking, it starts at the very beginning. If you're setting up a program, you've got to be tracking your data early on. And, we have what's called a patient blood management timeout. It's like a surgical pause. It's at the end of every case. Now it's more automated so that we pull in data from the electronic medical record. But for years, we had the circulating nurse fill out a form and submit a paper form, and then we enter the data in for our patients, so that we at least had real-time data, even if it was on paper. And having that is indispensable if you're approaching insurance companies, if you're trying to get traction from the hospital for any resources and so forth. And then at this point, we're trying to get physicians, stakeholders into this process. And I would say that it's a global idea and it's a global strategy, but it's very, very local when it comes to being able to implement something that's going to work in your own hospital. You really have to build consensus, and then you have to make people as well as you can, make them understand how you make it safe and how their risk is less and how the patient's risk is less if you use transfusion-free techniques. So now we've got some major JW cohorts from since 1997 up until now. And then we started putting in some QA processes here. And that was basically, we were trying to make it so that the patient safety was secure, that nobody was trying to dissuade them from being a witness and refusing blood products, and that people understand that they weren't going to get phlebotomies and that the patients could refuse blood draws. And so all the things where you've got friction between the environment that is there in your hospital and the beliefs of the patient, and sort of deter the hospital environment away from the idea that, it's another witness, and oh my gosh, we're going to have to bend and possibly break to support their practice. And the whole idea is that we're trying to form a safety net that works so that nobody has to bend or break. So then in the last few years, what I tried to do, there's a couple of things. One, I wanted to set up a credentialing module for a TFS PBM program, but really there needs to be a credentialing module for transfusion practices in general. We've got to do them for harassment. We've got to do them for equity and diversity. We got so many health stream modules that we now have to do, but yet it seems like the whole idea of transfusion practices has gone fallow, and there's really no way to grow people's understanding, a practical understanding of how to minimize transfusion and conserve blood. Okay, so then the last thing I think is to build hospital-based committees, and through those committees, you sort of modify the appearance of the program, and you develop influence in the blood banking, tissue, and transfusion committees, possibly in the pharmacy and therapeutics committees, possibly looking at point-of-care testing in the operating room for thromboelastography and so forth. So then, in the end, this is what I see as a blueprint for the program, and these are all the things that I just told you. You first start off, you develop your data tracking very early on. You don't do the hard patients early. You get critical pathways so that you can identify where the rubs are between the Jehovah's Witness population in this particular case and the hospital typical administrative practices. Get anesthesiologists, and most importantly is to start publishing early on or presenting, even if it's just local stuff. We have 47 peer-reviewed articles just from our own division. And, you know, we're in the process of doing up the global experience that goes all the way up through the end of this year. It'll be close to 3,000 patients. So, and then these things are sort of added, I guess, ballast to the whole idea of a program. If you've got a QAPI part, especially a patient blood management policy, you can get people to buy into credentialing module. These are things that really give it traction and make it really part of an integrated program in the system. So I did want to say a little bit about A&H because of all things, A&H is the godsend for the surgeon and for the anesthesiologist. And the nice thing about it is it's so simple to do. It doesn't require a consent. It requires a willingness of the anesthesiologist to do it. And the physiology of it is quite amazing. And it's just a representation of the fact that, you know, anemia is well tolerated by the vast majority of patients. This is the physiology that happens if you read it from right to left. Once you take off blood and replace with colloid or crystalloid, then the heart rate goes up as a compensating mechanism. And of course, the SVRI is going to fall, and then the stroke volume index goes up, and the cardiac index goes up. So it's a real simple measurement of a physiology principle in action. And then you keep your oxygen delivery and your oxygen consumption are supported until really at a hemoglobin of around 5. And I'll skip that slide. So just so that you know, you don't have to have the whole hospital decide the practices of patient blood management. You as an individual surgeon or anesthesiologist can practice it in the operating room. And that's where I find it of most benefit. So on every patient that we have that gets a liver resection or a Whipple or anything that looks like it's going to be more than a 300 or 400 cc blood loss, we do A&H on them, all of them. We don't do cell saver that often because it so often happens that you set it up, you pull off some blood, maybe 100, 150 cc's, and then they throw it away. So we don't usually set up for the patient blood management. We usually don't set up a cell saver, but we always do A&H now, always. And we don't have that 1 unit blood transfusion. It's really gone away for our particular service. So I think that the A&H is a strategy that transcends the witness population. It should be very central to patient blood management. I'm sorry if I'm running behind a little bit here. So here in our population, we've done over 2,500 patients, and I'm not talking about endoscopies or hernias or tonsils. I'm talking about, you know, major procedures since 1997, and this is my take on it after all this time. If it's an elective operation, you better have a normal hemoglobin and a witness. You absolutely better. And if you're expecting bigger blood losses, you can get a hypernormal hemoglobin, even if you have to, obviously there's a black box warning for hypernormal, but if you're going to need it, you're going to need it. So you can tell the patient, get a consent, and even anticoagulate the patient pre-op. This second one is the most important thing for surgeons. I don't know how many surgeons there are in the audience, but if you're going to do obligatory, transfusion-free practice, you better know what your expected blood loss is going to be, and you work backwards. In other words, you know the procedure, you know the circumstances about the patient. Is there portal hypertension? Is there a lot of previous surgery? Is there obesity? What's gonna augment your need for blood as a safety net? And then you once you anticipate this, you work backwards and you pull off the amount of ANH that you're going to need to support that blood loss. In the operating room, you cannot have hypovolemia if you're going to promote anemia. You've got to have monitoring, and that's kind of disappeared in this day and age with CLABSI and CAUTI and all that. That, you know, this is counterintuitive for the management, for patient blood management, I think, and central monitoring. Everybody knows that there's redundancy in the hemoglobin, and there is a lot of redundancy in the clotting factors. So we're lucky in this regard because it allows us to take off whole blood and dilute down. I'll show a slide about that. And then post-op, we have to be more vigilant about phlebotomy. Tell me how I'm doing for time if you... So this is our patient blood management timeout. I just wanted to show this because it basically is a register of the patient's kind of procedure. Is it an emergency? What's the nature of the procedure? Starting hemoglobin, type and cross yes or no, ANH utilized and how much you took off, how much estimated blood the EBL was, and cell saver and so forth. So these products are manipulations are very valuable if you're gonna start data tracking your patients. I'm gonna skip that. So here's, whenever I think of the blood system, I think, okay, we're basically manipulating the blood system, and each element may have to be manipulated in the course of an operation. It certainly has to be anticipated. In other words, are the coagulation factors normal? Cellular elements normal? Do you have fibrinolysis? And if you think you might, you need point of care testing with a thromboelastography so that you can give the factors that can prevent the fibrinolysis. Intravascular pressures are very important, and sometimes I'll even pressure transduce the portal vein or even put a pressure transducer in the liver proper just to make sure I don't have high or low pressures. Vascularized adhesions can be a nightmare in a transplant patient. So all those things are gonna pre-exist, and you can anticipate when it comes to the ANH. And so this is the most important slide. And we just published an article on tertiary level HPB surgery in witness population. I think we had 70 or 80 patients. It was in Annals of Surgery a couple of years ago. And this, we did our calculations. This is for hemoglobin reduction with each aliquot of ANH that we took off. And this is for a 70-kilogram male, and you've got parallel structures for females or higher or lower weight, but it mirrors this. And so this is the ANH removal volume on the x-axis down below. You've got 7 units that you can take off as you're hemodiluting in real time. So you're dropping your hemoglobin from 14, 15 down to 8, just below 8. And so you can get off 7 units of ANH and park it at the, in the cooler or in the, whatever vehicle you've got for holding it, a rocker or something. You can park it there and use it as you need it. There is nothing more assuring, even on a transplant, than to have the anesthesiologist and the surgeon look over and see that they've got blood in the room. And that eliminates the fight with the blood bank to get the blood up there, which is often a big fight. And maybe it's 20 minutes, maybe you're lucky and it's 2. It's always on the way, but it's never in the room. So this is the most reassuring thing that you can have as a surgeon or as a program manager or an anesthesiologist, is to have as much ANH as you think you're going to need to offset the blood losses. You don't have to do this calculation if you're just doing patient blood management. You can say, well, it's safe enough to take off a couple of units. We'll do that. And then if we lose more than we need after that, after we've given the ANH back, then we're good. So I wanted to, and abiding by this particular principle has saved ourselves so much grief. And I'll show you in just a minute when we took off 7 units of ANH on a patient for 3-liter blood loss. So over the years, we've checked on the amount of blood loss that's a likely expectation for big procedures, because if we're going to use ANH in the most sophisticated way, it would be on the hardest cases. And if you can use it and effectively on the hardest cases in a witness, then we're home free. The requirements for blood banking and blood administration would go way, way down. hospital costs would go down. So this is what expectations are for these particular procedures. For HPB, lobectomy, triseg, Whipple, distal, retroperitoneal sarcoma, for foregut, esophagus and stomach gastric resections, big, AP resections and pelvic floor for the colorectal, cabbage, mitral valve, aortic valve, pneumonectomy and lobectomy. And these are all, 500 plus cc's of blood loss. And these are, for the most part, I would say 95% of these in our data collection are elective operations. So we've got an opportunity to manipulate the patients ahead of time. AAA, a lot of these AAAs were actually ruptured, and so those were included in the data. For neurosurgery, these two knee replacements, redo knee replacements were also, knee and hip replacements were also in here. And a lot of times the blood loss in these is post-op in the drains, radical hysterectomy, and here's some nephrectomies, cystectomies, prostate, and so forth. Let's skip that slide. So this is our data from 97 to 2021. I haven't re-crunched it yet for the last 3 years, but that's what our global publication is going to be about. So we've done 34 kidney transplants up until that date, 3 donor nephrectomies, 4 pediatric liver transplants, 3 live donor. These are cadaveric, these were live donor. 41 liver transplants in adults, live donor, 6 cadaveric. That's where the highest mortality was. 37 22 Whipples, 14 distal pancreatectomies, and 62 major liver resections. So these were almost all of these, except for 1 liver resection and 3 cadaveric adult liver transplants, were all elective cases. So they were all prepped. The 3 patients that we lost on the cadaveric were all highly decompensated. We shouldn't have done them. And the one that we lost here was a ruptured liver tumor. Everything else was elective and was successful. I'm just going to say, how am I doing for time?
I would say 2 to 3 minutes.
I'm sorry?
2 to 3 minutes would be good.
Okay, I'll skip it. Basically, this just says that if you use a cell salvage, this is from a study at Mass General, if you use cell salvage and you have an R0 resection, you're not spilling circulating tumor cells in the blood, and you can use it freely. So we now, on all resections where we're expecting a clean resection with a clear margin, we're using cell salvage. I'm going to skip this live donor liver transplant because I wanted to get the last slides in. Okay, so this is our experience with the first 5 witnesses that we had. And starting hematocrit here, not hemoglobin, but hematocrit, the number of units we took off, and how much the blood loss was for this particular patient that's starting hematocrit of 49.5, and then how much we gave back in the cell saver and the final hematocrit. So this guy had his spleen and liver were stuck together. He had a 2-stage operation, got a liver transplant, then later on we came back and took a remnant piece of the liver that was stuck to the spleen off. He lost 2,900 cc's of blood in the first operation. He had, it's almost 2,800 cc's of cell of ANH, and he ended up with a final hematocrit of 44, almost 45. So this is consistent throughout all these. This is the most we ever took off, and he didn't turn a hair. It's a slow process. You don't, get it all off in the very beginning, and there's no urgency about taking it off, especially as you march through the first hour of the operation. But by the end of an hour, you've got 7 units of ANH, and this guy was a save. This is a comparison between transfusion-free and transfusion-eligible patients, pre-op, hematocrit pre-op, post-op, median units transfused 0 and 4.5. And I'm going to skip that. Okay, so for the rest of these I just showed you the hepatobiliary, but these are the other patients. This is a cardiothoracic surgery, heart transplants, cabbages, thoracic aneurysm, valve replacement, sternotomy, pneumonectomy and lobectomy, diaphragm hernia, lung transplant. Oh, that's wrong. That's a mistake. I'm sorry. The total knees and redo total knees, shoulders, and hips, and then redo total knees, shoulders, and hips, implant removals, open reduction, internal fixation, laminectomy. These are often bloody. Scapulectomy, sacrectomy are bloody. For GYN, so you get the picture. I mean, it's the toughest surgeries. For every service line has their bad actors. And this is basically a testimony to the fact that if it has to be done transfusion-free, it can be done using a strategy. And this, again, these are not, very few of these were emergency surgeries. Before I got into colorectal, the same things. This is vascular, AAA repair, open amputations, vena cava excision. Some of these wouldn't require blood normally, but a lot of them do, a lot of them. So we've included in all this is the top 20 procedures that you would see in an institution that's a tertiary, quaternary level institution where they would lose a lot of blood. And that's it for that. This is an old slide. I love this slide because it mirrors my experience. It was just a slide at one of the hematology meetings, but it was what's the tolerance of an anemia? So here's 6 to 7, 5 to 6, 4 to 5, 3 to 4. And you can see that it really doesn't fall way off until you hit about a hemoglobin of 3. And this is my experience. I had 2 patients that got live donor liver transplants, and 1 patient I took to the operating room with a hemoglobin of 2.5, and she had a cryptococcal peritonitis, and she had the debridement, and she survived. Went home. I'm going to skip the phlebotomy thing, although it's a pain for me. So I think that the great part about our experience is that we've basically shown that elective surgical cases of almost any kind can be undertaken, certainly with patient blood management. That's a no-brainer. But even with a witness, if you develop the strategy and you've got people that are willing to understand and participate in the strategy. However, our biggest problem of all is that we have very little penetration of the core practices, ANH, cell salvage, blood augmentation, and those are so simple, except for a pocket full of true believers. And it's been that way, at least from what I see. And I've practiced at a lot of different hospitals in Southern California, and it's the same story everywhere. Unless you're in there pitching on every patient and you're a major leader in the operating room in those institutions, you're not going to get traction with transfusion-free practice. Okay, well, I think I'll stop there.
Okay,
Dr.
great.
Shelley, that was really a great presentation. Sorry if you were feeling rushed. We did not mean to make you feel that way. I know we have to move on to Q&A, but I did want to say a few takeaways that I really appreciated, and I'm sure everyone did too, is just how with your hospital system, how necessity creates the need to create a department. And also it looks like you ended up building the A team relatively quickly, which really helped with your patients. So for that. At this time, Dr. Rafai and I would like to introduce the Q&A. We do have a few questions in our Q&A board. And if we can take down the presentation.
You want to stop sharing,
sharing?
Dr. Shub? Yes, please.
Okay, stop share. Okay. Okay.
So we would like to introduce our panelists. We have the Q&A board. We want to just go over real quick here. We realize we're a little limited on time, but we would also like to focus on these questions, focus the attention on our presenters who shared this morning. So Dr. Rafi, would you like to lead with the questions?
Can you see the questions? Let me see.
Some of these looks like they were from this morning's panelists.
From the morning panels, yeah, I'm trying to. I think it starts from here. There's a lot of thank you, and would like to.
The question on how to get anesthesia buy-in.
You got one?
How to get anesthesia buy-in? Is that what you said? Well, and I did have some slides about that, but I think the best strategy is really to find a way to compensate them. There's a billing code for it, but in our part of the world, anesthesia won't pay for that billing code. So I think that there should be a dedicated effort within the hospital side of blood banking, and to look at how they might either provide mission support for the Department of Anesthesia or individual support. Just pay them, pay them some way. You pay them. The other way is to get them involved in local, regional, even national presentations and publications. So once they understand the strategy, they love it. For our liver transplant team here, we have 4 or 5 anesthesiologists, and they don't even ask anymore. Every patient they do A&H on, and they don't even ask us. They just say, okay, we got 2 units here. I thought that's all we'd take off. Non-witness. I said, okay, great. They're all Egyptian too, and somehow just it draws people from Egypt, I guess, because we've got 5 of them, and they all are just fantastic. But I will say that practice hasn't, it's not like COVID. It's not spreading to everybody in the service, in the anesthesia service. But I think if you get them involved in it, have them maybe even park them on a committee or two, and it requires a leader. I think it requires a leader in the center to have a vision about how, what to do, what you need to do, and then how you're going to do it. And that's why I was showing those slides of how we march through the development in our own program. So.
Yeah, it looks like your strategy-based approach has really helped everyone as a team, and being in such a big metropolitan area, where you have such a big wide variety of cultures.
Yeah.
Let alone
that's for sure true. The anesthesiologists have independently presented their own data at multiple meetings. I mean, it puts them in the upper crust. If you're doing spinal surgery with no blood, or radical hysterectomies with no blood, then you're popular and people want you to talk.
There's one question here. It's not addressed. Anyone of you can answer this question, guys. Would more public awareness regarding anemia be of support?
Is that for me? The question for me or something?
Any one of you guys.
Oh.
It's in general. Would you support the awareness of anemia and management of anemia before surgery to the public?
Well, I can answer that because I have an opinion about it. We see a fair number of patients. In fact, JCO tracks it now. JCO tracks, I think, most hospitals to see what their practice is around regional preparation or hospital preparation for elective surgery. I think the thing that would be more important would be to have the insurance companies plug into it a little bit and get them to agree to augmentation of the patients, because that's always a struggle. It's always a struggle. And I think that's what deters a lot of physicians, surgeons in particular, from trying to work through the algorithm of blood augmentation, is because it's a fight. And it's an authorization fight. And then patients get nervous if they've got a malignancy. They don't want to wait another 4 weeks or 6 weeks. And so it's off the table. So I think that's the biggest issue.
I think you bring up
oral iron just doesn't, if we're talking about iron supplementation, it's really not oral iron. It's IV if you're going to get them up to speed, with or without erythropoietin.
I think you're bringing up a good point, Dr. Selby, in that for the most part, blood transfusions are not built into the DRGs.
Right.
With insurance.
It's a cost the hospital is going to eat.
Hospital eats all of that. And really that's, something we're giving that we really don't have to in that case, especially if we're using meticulous practices. And
right.
That's optimizing using PBM is such a wise decision to go with, but also looking at it from prior to the surgery. That was a good list you had, was the blood loss expectations, just to know what you're going into before going into it, so you can have all your tools. Oh, I also like Dr. Yakubu with your refresher because PBM, the refreshers are so, they're there, and yet it's good to review those every so often. What all can PBM do for not just the patients, but also for the staff, the team?
Thank you, Sandra.
Any other questions, guys? If you feel free to put your question on the Q&A session. Doctor, there'll be someone asking how they can get in touch with you. So they are doing an awareness on donor organ and anemia awarenesses. So
Oh yeah, my email address is rselby@surgery.usc.edu.
Thank you.
I can ask a question of Dr. Knight. Great presentation, and certainly tolerance of anemia is something we believe in here as well as on the pediatric side. But at the same time, there's a lot of data in the cardiothoracic surgery, anesthesia, perfusion literature, combining EMR and data collection with the importance of avoidance of AKI and DO2, continuous DO2 monitoring. How do you merge those two things? I certainly know where I stand, but I just wonder if there's a way that we can, certainly tolerance of anemia all the way down to 7, but there's other studies out there that show that maybe we should be higher than that to prevent kidney injury.
Yeah, I think it's very patient specific. And that's why, in my mind, it's important to identify who's has the most to gain from aggressive anemia management and blood management, which is the younger, healthier people who also happen to be the ones that tolerate the most pronounced level of anemia. I do think in a sicker person, you have to tailor that thought, older, sicker person. And in our population in cardiac surgery, it's really two separate groups of people. It's the elective outpatients, which are exemplified by minimally invasive mitral valve repairs, which are almost always completely elective, versus the urgent inpatient cases where our options are somewhat limited, and where, although you could theoretically say, well, let's delay their operation and try to get them less anemic. If you're in the hospital, the last thing that's going to happen is an improvement in your anemia. It's only going to stay the same or get worse. There's two different groups of people, and the strategies have to be a little bit different.
Great. Thank you, everyone, for this session. It's a great presentations, great questions and answers. I appreciate your time and appreciate your effort. With this, we'll come to the end of this session. There's still one more session for the industry presentations in the next 15 minutes from Dion Osemwingi talking about HemoClear. For us, this is all set for this session. Thank you very much.
Thank you.
Thank you, Sandy.
Thank you all.
Do I go ahead and jump in with the presentation?
Oh,
I'm so sorry.
just me. Paul, I'm sorry. It looks like your co-moderator is not available.
Oh, okay.
Yeah,
No, I'm
sorry
right
about
here.
that. So
Okay,
you can go ahead and introduce Dion.
okay.
Yes,
So,
sorry.
so let me go ahead then. So greetings from the cold winter morning from Edmonton, Alberta, here in Canada. So thanks for hanging on for this industrial session. So I'm Paul Agbolu. I'm a clinical pharmacist. I'm project lead with the Canadian Blood Services here in Edmonton. So with me, again, I must apologize. My co-facilitator is not here, so it's likely.
Oh, she's here now. She's here now.
Oh, okay, Deborah. Yeah, okay. So Deborah is my co-facilitator, and she's an acute care nurse practitioner and a general cardiology at Yavapai Medical Center, Prescott, Arizona, in United States. So let me hand over to Deborah to introduce our first speaker. Deborah.
Good morning. Good morning from Arizona. And sorry, I have a patient arriving early, so I have to step away in a second. But I hope you've all been enjoying the conference as much as I have. And I want to introduce Diane Osamwenge, Global Business Development Manager, Hemoclear BV, the Netherlands. And she's going to speak on the Hemoclear microfiltration cell recovery. So please go ahead, Diane. Thank you.
Thank you very much, Deborah, for the introduction. I have to say, while I get my slides up, there's a few times a year where I really regret not having studied medicine. And this conference stands in the top 3 of moments where I really regret it. It's always so inspiring and interesting to hear all the presentations. So I really appreciate the opportunity to speak here, but also especially learn from you. I've just shared my screen. I hope you can all see it well. So I assume that you do. I'll go ahead and get into it. So today I just want to share a little bit with you on Hemoclear, which is a technology that was invented to support the boosting of autologous blood transfusion use. It is something that supports cell salvage, and it does so by microfiltration. And it was invented by a cardiac anesthetist. I think he's also here with us today, Dr. Arno Nierich. So I'll take you along in the work that we've been doing with Hemoclear and are looking to continue. Per introduction, and I'm sure that I'm preaching to choirs here, but just for the sake of starting from scratch, I think when we all talk about patient blood management, you recognize the 3 pillars, and in the back of your mind, and hopefully also in the back of patient's mind, is the common notion that one's own blood is the optimal blood. Everyone here could do a phenomenal job explaining that recovery of those valuable patient blood cells when lost is an important part of patient blood management. Everybody, I think, also is aware of the fact that the blood needs to be made safe, needs to be processed before it can be given back, and the gold standard technology to do so and remove those potentially harmful contaminants such as bacteria and free hemoglobin is a centrifugal machine. Even though it's very effective, especially at capturing the red cells, there's also some downsides to the technology, being that it's quite complex, it's costly, and usually it's confined to the operating theaters that can afford to have these machines in place with a dedicated operator as well. In the resource-limited setting, anywhere a bleeding risk is not very predictable, the machine often isn't practical, it's not affordable, and therefore they're not an option. So this lack of widely available technology to use remains a limiting factor in the use of high-quality cell salvage worldwide. And from these facts, Hemoclear was actually born. So Hemoclear is basically a solution that does the exact same thing as a centrifugal cell salvage machine, but in contrast to the machine, it uses simple microfiltration. It's gravity-driven. It's an easy, straightforward procedure. There's no equipment. And as a bonus, the filter also recovers the platelets to give back platelet-rich red blood cells. The procedure is simple and straightforward, like I said. This is a marketing picture, obviously, but in the essence, you'll probably recognize it from the cell salvage procedure that you already know. The collection in HemoClear is exactly the same as with the centrifugal machine. It's suctioned intraoperatively, perhaps collected in a drain postoperatively. And then in the second step for processing, in case of use of HemoClear, the blood is simply hung above the filter device and it's filtered in 2 rounds. That takes up to, let's say, 25 minutes. Could be quicker if the blood is more diluted. And then the blood is ready to be reinfused to the same patient immediately. Today, I zoom in a little bit more on the use of microfiltration cell salvage in obstetrics. I've talked about it before and during the last conference. There's a lot of reports on the obstetrics department representing a lot of donor blood consumption, up to 40% in some countries, particularly in the lower middle income setting. Postpartum hemorrhage and anemia in pregnancy greatly contribute to the maternal mortality and morbidity, and also well described in the literature and explained by a lot of leading physicians that are also among us today. Obstetric care might still have a lot to gain from patient blood management, and more specifically from the autologous blood transfusion use and options. So having validated, when I talk about HemoClear, the safety and efficacy of microfiltration in producing autologous blood, next questions that arise to successfully support extended use of cell salvage in the obstetric setting is whether it meets the health system and adoption requirements. I heard Dr. Salvi just mention that core practices are there, but they're used limitedly. So I guess in the same line of thought, we're also thinking of how do we most optimally integrate this new system in current transfusion practices, and with that, additional questions about financial feasibility, but also about implementation plans, clinical leaders, clinical guidance arise. At the moment, we have various trials that are ongoing in the obstetric setting specifically. On the one hand, we continue to collect and reconfirm the clinical safety, continue to monitor effectiveness, especially when going to a new setting or a new country. Here you see a diverse range of countries that have some overlap in terms of context and setting, but on their own way are also very different. In South Africa, a trial was recently finalized in the obstetric setting, cesarean section specifically. Then there's another one ongoing in Germany. And especially talking about how do you get from implementation to wide adoption, there's a trial that we run in Nigeria with various partners that goes beyond looking at clinical data or in vitro data, but also looks at stewardship, cost effectiveness, implementation, adoption. So I'm very happy to share a little update on each of these studies today. Here you see a video of Dr. Ramatseya. He has been one of the leading physicians in South Africa in general in implementing the new system in the obstetric setting. And yesterday evening, we were in a call where he shared the exciting results of his study that he just finalized. Because he is in the process of writing a manuscript, I wasn't allowed to share any graphs yet. So please bear with me on those. Hopefully in the next conference, we can share those with you. For now, his main findings are that the microfiltration showed good recovery of the cells, and he also confirmed the proper washing. So this is not new data. We already have some data on it, but now coming from the South African setting specifically. A very different setting is Germany. And here you see a picture of Dr. Hept and Professor Steinbicker, who are currently specifically looking into the recovery of platelets with HemoClear and the inflammatory reactions in cell salvage, comparing HemoClear microfiltration to the centrifugal device that they do also widely use in Germany. They are focused on cesarean sections, and last month during the German annual anesthesia conference, they presented some interim results. And those results for now are that HemoClear recovers a higher number of platelets compared to a centrifugal device. So that's confirming what we knew, and they will continue to enroll more patients. And with new data, they will also include FACS analysis to have a better look at the platelet function of the final processed units with the Cell Saver and HemoClear. Then in Nigeria, as I already mentioned, we have a pilot which is a little bit broader than just clinical. It also looks at the implementation endpoints. And this is let's say, large projects with a lot of collaborators. And I start smiling when I mention them because really they're such a great group of experts. And those are the National Blood Service Agency Nigeria, which is the leading party in this pilot. We collaborate and are funded fully by the FIT Fund, who really have taught us a great deal about theories of change and looking beyond clinical aspects. And then the two pilot sites are the University of Abuja Teaching Hospital and the University of Calabar Teaching Hospital, where we were welcomed with a wealth of clinical experience, but also great thought leadership. So really, this is a great combined effort to explore how this new device can optimally be implemented, looking at both the clinical requirements for implementation as well as the practical ones, and collecting data on both. So in terms of the implementation endpoints, there's been, I'll show in the next slide, but there's been various training events where we actually looked at, what is the baseline knowledge that the participants, the trainees have already on cell salvage in general, and then on microfiltration cell salvage, collecting their subjective opinions on both the training, but also the technology and the procedures that the technology is used in, and actually measuring the timing. How long does it take them to set it up? Are they comfortable in setting it up? Then obviously also clinical data is still very important. So for the use of the system, it's been looked at and is continued to being looked at. What is the volume that is processed? What is the blood loss? Patient blood hemoglobin levels are measured, and full blood counts also. So it's let's say a teaser for the first data. The training events have been finalized, and in general, the first results are very positive. Both groups, I said it during the last meeting that we are all here for BMSS. Both groups are very highly motivated. They have a very pragmatic attitude and strongly solution-oriented, which I hope it's not just typical for Nigeria, but it was definitely something that was remarkable. In the training, every training was, or every trainee was tested, let's say, to set up and demonstrate use of technology. Every trainee was successful. The average time that was necessary to do so was 3 minutes and 10 seconds. And before the training, in the intake exam and the training groups consisting of consultant nurses and residents, the average number of correct answers to the questions was 53%. So there was some baseline knowledge. And by the training, this increased to 76% on average. Always room for improvement, but there were also some that scored 100 after the training. So those were very good results and very motivating results to obtain. At the moment, close to 100 women have already been enrolled as clinical participants. This trial will continue to further enroll clinical participants, and hopefully during, let's say in May, for the next event, we'll be able to share an update again and also share some of the clinical data, which I'm already excited for. So those are the brief updates from my end today. Thank you again very much for having me, and I'm happy to answer any questions.
Yeah, thanks, Dion. That was a very good update. So I think I have a question here. So let me just read this out. It says, "Hi Dion, well done. I'm not a surgeon, so please pardon my probably very elementary questions. Would your product replace Cell Saver?"
Okay, that's a good question. I'm also not a surgeon, so I think I can answer it in the right way. The short answer is no. So the product was invented to come in anywhere that cell salvage is desired, but there's no technology yet. So if the cell saver is already implemented somewhere and they're happily using it, everything is in place, then I'd say continue to do so. There's no need to make a change. But wherever it's not possible yet, because the cell saver is not there, because it's not practical or it's not available or not affordable, that's where this product could be used. So it's kind of an add-on and not a replacement.
Okay. Thanks for that question. There's another one here. It says, what is the cost of one HemoClear unit?
Also get the question often. I hope the answer that I'm going to give is not disappointing. The cost depends on the country. We work globally and the cost is not the same everywhere. So I'll give a general answer. When looking at the procedure, the intention is to have this product always cheaper than donor blood. And often we manage that, and at least as cost effective as a cell saver. And so far, we've also managed that in the countries that we're currently operating in.
Okay, I think Nat will. Did I see Nat wanting to say something about the cost here? Nat?
Oh no, not at all.
Okay.
No.
Because I just saw something popped up here that you'd like to say something about the cost. Okay. I think, I don't know whether this question is for you. Regarding donation, we're finding that 60% will be heading for donor procedures, while 40% on the list. Would education regarding PBM help to introduce the concept to the patient?
So that's not for Dion.
Okay, I
The
don't
only
think that's for you,
question
Dion. Yeah.
Yeah. The only question left for her is, are you in use in US? I think that's the last.
Okay.
Whether we're using in the US, not yet. Not yet. Only in, let me not share the whole list, but US is on the planning. Let me put it that way.
Okay. I think that's all for the question. Thanks, Dion, again for a wonderful presentation.
Thank you very much for having me.
Thank you very much. So I think we're going to move I would like to introduce the second speaker, Dr. George Uchenna Eleje, a professor and consultant obstetrician and gynecologist at the Nnamdi Azikiwe University Teaching Hospital, Nigeria. His presentation will be on the novel indigenous advances in bloodless medicine and surgery in Nigeria, clinical trial experience on Mojiga remedy. So he's going to talk to us on, some of the trials done on Mojiga remedy. You're welcome, Dr. Eleje.
Thank you. Can you see my slides?
Yes.
Okay, you can see it? Okay. It's a pleasure to be present in this presentation as both as an academia and as an industrialist. It's my pleasure. I'm Professor Eleje. So one topic is on novel indigenous advances in bloodless medicine and surgery in Nigeria. These are clinical trial experiences on Mojiga herbal remedy. I'm a consultant obstetrician gynecologist. I'm also the Deputy Director, Research and Innovation at Nnamdi Azikiwe University, Awka, in our university. I have no conflict of interest. Actually, most of this presentation, these have been published in +1 this year. As you can see it, the clinical trial registration number is there. We also register with NAFDAC Nigeria, who supervise the trial because it's an indigenous product. So why do we say it is novel advances? You know, anemia is a major cause of major public health burden worldwide, particularly in low and middle income countries. WHO estimates the prevalence of anemia among pregnant women to vary from 53.8% to 90.2%. So you can see that it can go high up to 90% in low and middle income countries, which Nigeria and other countries are part of it. But compared to high income countries, it's only 8.3 to 23%. And iron deficiency anemia. Okay, let me put it in slideshow. So iron deficiency anemia is often treated with oral iron supplement, even in pregnancy. So
I guess we're having some network issue.
yeah, can you hear me?
Okay, yeah, John. Good.
So it's not moving, but I can be talking. Iron deficiency anemia is often treated with higher oral iron in our environment.
Recording in progress.
Let me, it doesn't move. Let me just come back. I will share. Sorry. So give me a minute. So I will share this one. This one will open. Yeah, so this should show. Yeah, so Mojega Herbal Remedy, produced by Mojega International Ventures Limited, is a natural indigenous preparation. Can you see me? Containing a triplex of Arconia, cordifolia, penicetum, glaucum, and so on bicolor extracts. So it's a triplex of these 8 ingredients. It contains free organic oral iron preparation, among other nutrients that allows co-administration with conventional hematinic. So when the trial was, this drug was indigenously produced in Nigeria by Mojega International Ventures Limited, and it was approved under listing status by NAFDAC. And that is also what gave us an impetus to conduct this trial in Nigeria. The The mechanism of action is unknown, but it may work by mopping up the free radicals and reactive oxygen species. It will quickly reverse lipid peroxidation and cellular damages. It also increases levels of packed cell volume and hemoglobin, and contains antioxidants and natural mineral iron. So it has a strong anti-inflammatory properties also, which enhance general body metabolics. These are various possibilities of its mechanism of action. They also have additional benefits. It can be administered in relatively high normal doses in a short period of time. And that is why even in the trial, although we use 15 mL, which is made up of 200 milligram, 12 hourly. But if you give up to 100 mL, which is made up of 400 milligram, that dose also works. So before the trial, an anecdotal report, a case report, which we published, an expert opinion revealed that if you combine Mojaga with other conventional ion therapy, it may be superior to conventional ion therapy and for the treatment of iron deficiency anemia. But we also found out that there was, prior to this trial, no randomized trial on it. So it's also uncertain whether women receiving this combined Mojaga and conventional therapy will achieve desired hematocrit target faster with fewer side effects. It's also unknown whether their combination will further improve hematocrit levels or will cause adverse effect without hematological or functional benefit. These are all unknown before the trial. And then we decided to conduct the trial. What you are seeing a picture are some of the patients which were involved in the trial. Some of them had fibroids. Some of them belong to Jehovah's Witnesses who refuse blood transfusion. And some of those patients were given this drug prior to the surgery and they build their blood before the surgery. Then subsequently after the surgery, once 24 hours after surgery, once they start oral intake, they also go back to Mojaga herbal regimen. And of course, they didn't receive any blood transfusion, both prior, intraoperatively, and post-operative. This is a fibroid that the patient that had up to is 8 week size. And she was having a lot of menorrhagia. So we have to work her off a month with Mojaga remedy. And after the surgery, continued on it for 2 weeks. And post-op hemoglobin build up within a short time. This is also another fibroid operation we conducted which also reported in the trial that around the study, just as a case report prior to the study. This contains also this patient refused blood transfusion due to her religious faith, and she was on Mojaga. Initially, the PCV was 5%, that is 18%. But within 2 weeks after receiving the Mojaga therapy, PCV come up to 32, and she had the surgery performed without blood transfusion. And the patient also continued with Mojaga 24 hours, and he did well without blood transfusion. That's what we're talking about, indigenous advances in bloodless medicine and surgery. So to the best of our knowledge, this is the first randomized trial on efficacy of and safety of combined Mojaga and oral therapy and we also determine the efficacy, safety, and tolerability of the Mojaga remedy as an adjunct to conventional oral ion therapy, which is generally the standard of care. So we have used the Mojaga as an adjunct. The study was conducted in Nigeria, 3 teaching hospitals in Nigeria: Nnamdi Azikiwe University Teaching Hospital, Enugu State University of Science and Technology, Parkland, Enugu, and Chukwuemeka Odumegwu Ojukwu University Teaching Hospital. It was an open label randomized clinical trial. Then it's made up of antenatal women and also puerperal women. But the pictures I show are those who have gynecological issues. So also benefited from it, though they were not part of this trial, but they were part of the case reports we had prior to the trial. So these are the inclusion criteria. Pregnant women in the first trimester, we avoided the first trimester because of peculiarity of first trimester. Also, women that have HIV or other chronic medical disorder were excluded. Randomization, blinding, and participant and personnel. We randomize them using computer-generated random numbers. But here, only the outcome assessors were blinded. It was an open label study, not possible to blind the ion preparation and that of Mojaga. It was difficult based on the way it was prepared. So administer standard doses of 15 mL, which is 200 milligrams of Mojaga, 3 times daily for 2 weeks, in addition to conventional ion therapy, while the control group received only conventional ion therapy alone, the control group. So the participants were followed up on outpatient basis. During each follow-up weekly visit, participants were contacted on phone weekly to assess the level of compliance with the trial drugs. We also repeated the hematocrit level 2 weeks after initiation of the therapy for all participants. So these are the primary outcomes: changes in the hematocrit level and median hematocrit level at 2 weeks after initial therapy. Secondary outcome measures included persisting anemic symptoms, epigastric pain, weakness, and dizziness at 2 weeks after initial therapy. We also looked at the maternal adverse events like diarrhea, nausea, vomiting, colitis, and dropout from the adverse effects. They also looked at fetal outcome like preterm labor, PROM, and low birth weight and birth anomaly. Then hematologically and laboratory-wise, we looked at the liver and renal function test parameters. So we got ethical approval, got registered with Pan-African Clinical Trial Registry. We also got NAFDA registration for the trial. They monitored it. The study was conducted between 2020 and 2022. We recruited 95 eligible participants. Mojaga group were 48. Standard of care is 47. See the result. The baseline socio-demographic characteristics were not different at baseline, but median rise in hematocrit at 2 weeks follow-up was significantly higher in Mojaga group. It's 10 versus 6%. While median hematocrit values at 2 weeks follow-up were also significantly higher in the Mojaga group, 31 versus 27.7%. For secondary outcomes, there was no difference in tolerability rate. And also, Mojaga was associated with greater improvement in dizziness and weakness scores, but there was no serious adverse events noted. There was no recorded maternal or fetal death during the process. So we found out that the proportion of participants with persistent anemic symptoms like epigastric pain, weakness, and dizziness after 2 weeks after initial therapy were improved. In Mojaga group, but the anemic symptoms persisted only in 4.2% of Mojaga group, while in 8.5% of control group, it was persistence. And there was no cases of treatment failure. No cases of PROM or low birth weight. No recorded congenital anomaly. So it's safe in pregnancy if you use from second trimester. No changes in incidence of preterm labor or low birth weight in either group. Incidence of maternal adverse events were not different. Maternal adverse events were reported in 6.25 in Mojaga group, but 10.64% in control group. It was not significantly lower. But we look at the electrolytes, it's only bicarbonate that were lower in Mojaga group. Other electrolytes were normal, were equal. For the liver function test parameters, there was no difference after 2 weeks of therapy. So what are the strengths and limitations of this study? It was a good uptake and inclusion of representative sample of participants from obstetric units across the range of socioeconomic groups and hospitals. It's near complete follow-up. That's also another thing, allowing complete case analysis and limiting bias in the result. And therapeutic option for women with anemia, especially those who refuse blood transfusion like Jehovah's Witness faith. Before now, we have the low scarcity of alternatives for blood transfusion, that is oral. What we normally use is erythropoietin, and this erythropoietin is remarkably very expensive. And most doctors also think that it takes time for it to work. But Mojaga, from our findings, it doesn't take time. Within 2 weeks, there is a return of normal from anemia. Again, the intention to treat analysis was also employed in this result, and that showed result marked benefit associated with Mojaga, supporting the evidence of improvement in anemic symptoms. So what are the conclusions? Mojaga should be considered as a new adjuvant to standard of care option for treating anemia in obstetric practice. Following the trial, there have been a lot of prescription on that, and people are using it. We have a surgery we did last week, and patient also received it, and it did well. That surgery was carried out successfully without blood transfusion. We also had a case of a patient who had 4 previous surgeries. He's a witness who refused blood transfusion. He had a DPA card. So we also placed her on Mojaga, prepared her, put her up. HB was 9.9. Although surgeons initially opposed, but we carried out the total pleural hysterectomy, a bloodless surgery. Within 48 hours, the patient was discharged home, and he also received the Mojega. So Mojega remedy is safe for treating anemia during pregnancy and puerperal without increasing the incidence of congenital anomalies, low birth weight, and preterm level. These findings therefore suggest that the potential benefit of Mojega for treating patients with anemia and also support for further adequately powered confirmatory phases. We want to do phase 3 and phase 4 trials. We also need funding support, and that is what we're calling on all global community to support us in this phase 3 study, so that we can be able to do the study in a large way and prove to the world this indigenous novel product. We're also thinking of conducting a trial in pediatrics age group, because we also have a isolated case report of neonates that are 1-year-old children who in special care baby who received this Mojega, about 5 ml per kg, and they survived anemia they had. So it was also safe in neonatal age group. So this study has been presented in France last year, also presented in Australia during the COVID, and has also been published. It was sponsored by Mojega International Ventures Limited, which supported the study. These are the references. I had wanted also to show show us the drug itself in terms of the marketing aspect of it. It was already shown in the other slide. Let me try and show it here. The drug now available in both syrup and tea, the drug. So that is available now. So we have the syrup, we have the tea, and those of them are under investigation. The tea is under investigation. RAPDAC have also reviewed it, and we're working on it now. So people can take it in form of tea, like those who have post-surgery. They can take it 24 hours after surgery, and very good. The drug can also be think to be useful in other indications, which are also clinical trials are also being planned on it. Thank you for listening.
Thank you, Professor Eleje. Thanks for introducing Mojega remedy. So it's time for questions. Let me start. There's one here in the question and answer side of it, but let me just start. I know you are preparing for a phase 3 and phase 4. So the first question is, it seems also it's already in the market, so it's available in maybe drugstores and all that. But the question I want to ask is, have you started collecting data, safety data, in preparations for your phase 3 and 4? If yes, what's the data like? And if no, do you have plans to do that even before your sponsorship for your phase 4?
Yeah, thank you for the question. Yes, the answer is yes, because we considered it during the phase 2 trial. There was aspect of safety was considered. You know, this trial was used in children in pediatrics age group, those who are pregnant, in pregnant women. So we looked at some safety data at that point, because pregnant women are a vulnerable group, so to speak. It was really not easy to conduct such a trial in pregnant women, because the woman has a baby. In as far as it's anemia, the drug may be affecting the pregnancy. That's why they're a vulnerable group. So we have also looked at the safety data in terms of its affectation in the baby. Now, in terms of the woman who received the drug, yes, we looked at the liver function test parameters and the serum urea and creatinine, and to check the affectation. And we found out that there was no significant differences in those who received it and those who did not receive it. So we're also monitoring those babies who received it. But those trials have been conducted in 2 years ago. The babies who received it are being worked. So the first case report was before COVID, and those babies have been monitored, and they have not had any issue of side effect or congenital anomaly developing in the baby after delivery. So the safety data have been collected, and so far there's no problem, no adverse congenital problem or adverse post-surgery or post-drug, post-years, maybe after a year or 2 years after receiving the therapy, adverse effects. We have been monitoring them for the past 2 to 3 years now. So we're on course.
Thank you very much, Prof. Thanks. So let me start with a question on the chat, question and chat post here. So the first one says, I am familiar with Mojiga product. In the efforts to reaching the largest audience of anemic women in the fastest manner due to its critical issue, what do you deem would be the best outreach plan? That is to inform medical industry or concentrate on product awareness with the public of women?
Yes, we had it. Like last year, we had a gathering. You know, in Nigeria, we have some distributors of this product in all over the country. And also I'm aware that some countries outside close to Nigeria also distributing it. But in Nigeria, the manufacturers invited those distributors for this, where we had a presentation, and we had, so in all parts of the country, we had a presentation, discussed about the product and way forward. And that also distributed the message. We also have media. We have some media houses like those in the media, the NTA, those in the radio broadcasting, TV, and the papers, who came in, and from they interviewed some of us who are clinical trialists, and they had it. So that is another way of disseminating the products. And so far, virtually all cities in Nigeria have a distributor. But again, the trial have been conducted, published in international journal. So the journal is already publicly available. People are assessing it. The doctors who are using the drugs, they want scientific paper. They don't want story. They don't want any expert opinion. They want scientific paper. So we'll give them the journal, the link. They look at it and read. It's a way of disseminating the product. So that's being done. But we still hope to conduct the phase 3 and phase 4 trial in a large way so that it will give more robust nature of and also increase the number of patient selection in different parts of Nigeria and beyond.
Thanks, Prof. There's another one here for you. So is there any study on Mojiga alone, not in combination with routine oral hematinics?
No, there is no clinical trial on Mojiga alone. That is what we are planning for that phase 3 and phase 4 trial. You know, there was a challenge when we wanted to conduct it. That was a pilot study. Presently, there's no clinical trial on Mojiga alone. But that's what we're considering in the phase 3 and phase 4 trial. During the phase 3, phase 4 trial, we're going to have like 3 arms. One arm will be Mojiga alone. The other arm will be Mojiga and conventional therapy, while the third arm will be conventional therapy alone. So that's what we propose in the future trials. That is why we are proposing for phase 3 and phase 3 trial. But initially, it was not possible because NAFDAC did not approve having it alone without first showing that as adjuvant it works. So everything is a gradual process. But isolated case report, people are using it. So there's no trial on Mojiga alone. So presently, it's also be safe to combine it with any, so that you are taking it does not mean that you will not take the one prescribed by your doctor. You know, some doctors will also prescribe the conventional therapy. So using the Mojiga presently, we now use it as an adjuvant, and that restores hemoglobin within 2 weeks. We have been shown from that trial.
Yeah, thank you. I think this is the final one. So I'll take the 2 of them, but I'll just take them together. So if the first one is, where can one find Mojiga? Then the second one is, are you currently running AI models to promote the need regarding anemia awareness in the women of Africa, since this product doesn't require prescription from doctor? Would it give patients more options of selection?
Yes, for the first question, yes, the drug is available in, if I'm to say, every cities in Nigeria. Abuja, Lagos, Port Harcourt, Abakaliki, Enugu. So these are, you have distributors in all those cities. So for those who may not learn to know more of the distributors, I think if they contact me, I will direct them to the manufacturers or some of the distributors, and they will contact them. So for the second question, for AI model, well, no, not yet. But I know that these things are things we can do in future for conducting more studies, even the use of AI model. But as a matter of fact, it is available in the pharmacies, and patients can easily get it because you have an NAFDAC approval for Nigerian use.
Thank you, Professor Eleje, and thanks again for your hard work and your team giving us options. We actually need more options, and also wish you all the best to get all the sponsorship you need to go for those phase 3 and phase 4 trials. Would like to thank each and every one of you for this section. We are actually kind of rounding it up. Deb, would you want to give a vote of thanks to our wonderful speakers?
Yes, thank you, Dion, and all our speakers today. We enjoyed your presentations immensely. I hope you'll all return tomorrow for another active set of interesting sessions tomorrow. So thank you for listening.
Yeah, so thank you very much. I think we still have one more activity, but I just want to give you a preview of what is going to happen tomorrow. So tomorrow, we're going to have a first session, which is going to be a 7 session, that is bloodless medicine and surgery. And we'll be having topics on adverse outcomes of blood transfusion from 7. And also having another interesting, important role of podcasts and social media and contemporary bloodless medicine, a keynote address. And that ends the first session. The second session is on the art of bloodless medicine. And we'll be having the molding and shaping of a future of medicine through bloodless care and the Potter's perspective. And then it will end the day with an annual general meeting with the chairman, the BMSS president. It sounds interesting, so we'd like to see you tomorrow to continue this interesting session. On behalf of myself and Deborah, I want to thank you again, for this wonderful session. So finally, I think all the panelists and our speakers should be on. Let's just have some kind of a photograph before saying goodbye to everyone. Okay, just briefly. Okay. I guess that picture would have been taken by now. Okay, so fine. Thanks. Now, wish you all the best. And
it's not yet taken, Paul.
Oh, okay.
Yeah.
Have you taken it now, Nat?
I think Schneider is working on trying to put everybody there.
Oh, okay.
Schneider, when you're done, please let us know.
Yes, I will.
And as a matter of fact, we can also put things on oh, I didn't put on my camera. We can put things on on gallery view. And, Schneider, have you taken any pictures?
No, I'm still trying to get everybody spotlighted. So everybody can turn on.
Okay, what remains? Okay, so now can you all share your teeth? Thank you.
I think I have everybody.
Oh, good.
Let me just let me see. I think it's better if we just remove the spotlight. So everybody can just be on camera view. I mean
Okay.
on
Go ahead. Gallery, right?
yeah, gallery view. That
Okay.
way we make sure we don't miss anybody.
Right.
And so
Have you got the gallery view?
yes, it's on gallery view right now. If we
Okay.
can have Dr. LJ and Dr. Simatoe, if they would like to turn on the cameras. And Asen. And Udoc.
Okay.
And on Oyewu, if she's able to.
Yeah, they're probably busy.
Okay, so I'm going to take.
Tell me when to smile. I don't smile all the time.
All right. I don't think we. Oh, there you go. Okay. All right. So I'm going to take it right now. One more time. Give me a second. And everybody smile. Yes, I have it.
Okay. Over to you, Paul. Paul, you wanted to say goodbye.
Okay. I want to say goodbye to all. So hoping to see you tomorrow for another interesting session of this program. So thank you very much. Thanks.
Thank you. Bye-bye.
Bye.
Thank you, everyone.
Bye.
Bye.
Thank you. Bye-bye.
Bye-bye.
Bye.